Hi everyone, very good evening to each one of you. Hello guys, just a moment. Alright, so we are already done with the part 1 of the medicine, and today we are going to start it off with the part 2 of the medicine, right? Today we will be covering everything, whatever is left, we will be doing that thing, right? So please give me a quick confirmation so that we can start without any further delay. So today we will start it off with the cardiology part first. I would be making you understand what are the different things you should be knowing, and then we are going to start it off with the important things. Just a moment, guys. All right, let's begin. So in the given ECG below, PR interval is indicating what? Try to answer this question. In the given ECG below, PR interval is indicating what? So what is this PR interval is indicating? This is your previous year exam question. This is your previous year exam question. It is going to indicate what? Atrial depolarization plus AV conduction. Yes, you think so? Okay, come here. Let's understand with the basics of ECG. What are the ECG? How this ECG is getting formed? I'm going to make you understand very quick, right? So we are going to have multiple leads. We are having chest leads. We are having limb leads, right? So just a quick revision. We are having limb leads. We are having chest leads. Chest leads, right? What this limb leads and chest leads are going to do, basically we will assume our body in a form of a triangle, right? So we are going to add some leads over the extremities, and we are going to assume that my heart is in the center, right? We are going to assume that the heart is in the center, and we are going to take certain vectors. So in mathematics we have studied about vectors. For example, these two vectors are there, so I can take the vector like that. Okay, so this is the vector. On this particular basis we are having the ECG, right? So what is going to happen, let's try to understand. So this is going to be your heart. Let's say this is your heart, this is your right atrium, this is your right ventricle. I'm just brushing up the basics so that you can understand well, right? This is going to be left atrium, this is going to be left ventricle. First wall, that would be tricuspid wall, then we are going to have bicuspid wall, and here the blood will be coming from the body via vena cava, and the blood will be going via pulmonary artery to the lungs, right? And in lungs we are going to have oxygenation, and after oxygenation the blood will be coming to the left atrium via pulmonary veins, and now this blood will be going to the left ventricle, and from left ventricle this blood will be going via aorta to the body, right? This is the basic understanding of the, this is the double circulation that we always study, right? So now I am assuming that we are basically having a machine, right? ECG is electrocardiography, right? So basically we are going to assess the electrical current of the heart, right? So how we can assess the electrical current of the heart? We are having a machine, and that machine is known as galvanometer. You must have seen a machine, हम लोगों ने देखा है मोबाइल वगैरह में लगाते हैं. It will show a deflection. It will show a deflection whenever there is current moving, right? Whenever the current is moving, it will show some kind of deflection, be it your positive deflection, be it your negative deflection, right? So it is based on this particular galvanometer, right? It will be having electrodes, positive and negative electrodes, and now I am assuming that here, let's say here is going to be your negative electrode, this one is your positive end, right? We are attaching all the leads. Now what is going to happen, one more thing you need to understand, whenever the plus charge is moving towards the positive charge, it will be going to give you positive deflection. It is going to give you positive deflection. Whenever negative charge is moving towards negative, it is also going to give you positive deflection. If you understand this pretty much basic, everything will be easy for you in the ECG. Look here, so I'm just doing what, I am attaching a galvanometer machine to my body, right? And then I am assuming that my heart is in the middle, right? Heart is in the middle. In the heart, what is going to happen, you are going to have impulse generation from the SA node. It will be going to AV node, then it will be transferring to the bundle of His. We are having right and left bundle branch. Then it will be going to the this particular part, right? So this is going to be the arrangement. Here you will be having fibrous annulus, right? This is going to be the basic arrangement. Now what is going to happen? I am attaching a galvanometer to my body, and now it will be showing me some certain deflections. So we all know that current is going to generate in the SA node. Now what is going to happen? This current will be traveling into this particular direction, right? So the vector of this particular current is going to give in this particular direction, and it is a positive charge moving toward a positive charge. So what is going to happen? It will show a positive deflection. So I am just going to roll a paper beneath it. एक पेपर चला देंगे बस इसके नीचे, that is known as ECG पेपर. अभी क्या होगा? जैसे ही एट्रियाज में करंट जनरेट होगा, it will be giving you a positive deflection, going to give you which wave? That is going to be your P wave. Okay, जब भी कोई करंट असेस नहीं होगा बॉडी के अंदर, it will be giving you a isoelectric line. Okay, whenever there is no current, there will be isoelectric line. Okay, now what is going to happen after this particular point? After this particular point, what is going to happen? The current is in the AV node. current कहाँ पर है? देखो current कहाँ से move करेगा? ऐसे node में बनेगा. It will be going to your AV node. AV node is a place where lots of gap junctions are there, but they are haphazard. तो इनके अंदर क्या है? करंट हमारी मशीन असेस नहीं कर पाएगी, राइट? सो वेन एवर द करंट इज इन द AV नोड, what is going to happen? Our machine is going to take a isoelectric line, मतलब एक सीधी लाइन आएगी, यानी करंट कहाँ पर है? AV नोड के अंदर है. Now what is going to happen? This current is going to come below. अभी ये करंट पहले राइट बंडल ब्रांच की तरफ जाता है. This current is going to give its vector in the right bundle branch first. So what is going to happen? Right bundle branch की वजह से कैसा डिफ्लेक्शन आ जाएगा? Because it is a positive charge, and it is going in the negative direction, so we will be getting a negative deflection. Negative deflection आ जाएगा, opposite side में जा रहे हैं. So this one will be giving you a negative deflection. Then what is going to happen? Most of the current will be coming in this direction, because यहाँ पर myocardium क्या है? मोटा है, right? Left myocardium is big. So what is going to happen? It is going to give you again a big deflection. That is going to be your R wave, right? That is going to be your R wave. उसके बाद में क्या होगा? Now the whole myocardium is depolarized. पूरे myocardium के अंदर क्या हो जाएगा? Depolarization हो जाएगा. और हमारी मशीन क्या असेस करती है? और मशीन is assessing the flow of current. Now the complete ventricles are depolarized, so you will again get a isoelectric line. Because whole the ventricles are depolarized. Now what is going to happen? Now this ventricles will start repolarizing again. ये ventricles क्या करेंगे? Repolarize करेंगे. तो जो वेंट्रिकल्स का रीपोलराइजेशन होगा, उसमें नेगेटिव करंट किस तरफ जाएगा? ऊपर की तरफ जाएगा. इट विल बी गोइंग बैक, राइट? सो नेगेटिव करंट इज मूविंग टुवर्ड्स द नेगेटिव डायरेक्शन, लीडिंग टू व्हाट? लीडिंग टू अगेन अ पॉजिटिव डिफ्लेक्शन. दिस इज नोन एज टी वेव. राइट? This is your P, this is your Q, this is your R, this is your S, and this is going to be your T. तो basically इस machine में what we are seeing, we are basically understanding how the current is flowing in our heart, right? जो अपनी चेस्ट लीड्स है, दिस इज फॉर द लिम्ब लीड्स. जो अपनी चेस्ट लीड्स है, दिस चेस्ट लीड्स आर गोइंग टू डू व्हाट? सपोज माय हार्ट इज देयर, suppose my heart is here, so these chest leads are going to look at heart from these particular direction, right? तो जोन सी भी तुम्हारे पास में chest lead है, it is going to do what? It is going to look at the muscle, look at the heart from that particular direction, right? तो V1, V2, V3, V4, V5, V6, they are going to look at the heart from these particular direction. ऐसे समझ लो, right? सो वेन एवर देर इज गोइंग टू बी MI, मैं पढ़ाऊंगा आगे कैसे पता करोगे इंफीरियर वॉल MI है या फिर एंटीरियर सेप्टल है. तो हाउ यू विल अंडरस्टैंड ऑन द बेसिस ऑफ दिस पर्टिकुलर थिंग, राइट? So this is going to be the basics, first basics, right? Now two more things you need to understand. हमारे पास में दो चीज़ें होती है, one is known as segment, another one is known as interval. ये previous year question है. One is your segment. तो segment से याद रखो, S for segment it is going to be straight line. Segment is going to be your straight line. It is going to be your straight line. Interval में क्या होगा? Straight line plus a wave will be there. Interval में क्या होगा? Wave plus segment is known as interval, right? So we are having दो ही segment है हमारे पास में. कौन से segment है? First segment from here to here, this is known as PR segment, and second segment is your ST segment. Okay, so let's try to understand what are the things we are having. We are having P wave. P wave क्या इंडिकेट करती है बेटा? P wave is indicating atrial depolarization. एट्रियास कॉन्ट्रैक्ट करते हैं, यानी करंट कहाँ है? अभी एट्रिया के अंदर है. वी आर हैविंग P pulmonal, P mitral, राइट और लेफ्ट एट्रिया के बारे में बताएंगे, राइट। सो पी वेव इज गोइंग टू बी टेलिंग अस अबाउट द एट्रियल डीपोलराइजेशन। क्यू आर एस मतलब करंट पूरा कहाँ पर है, क्यू आर एस मतलब करंट कहाँ है, वेंट्रिकल्स में। पी वेव इज मीन्स करंट इज हियर। क्यू QRS means current is in the ventricle. Now ventricles are contracting, okay, and T wave is responsible for the repolarization. Now we understood what is repolarization, ठीक है। PR segment मतलब PR segment ये वाला segment हो गया, this is your PR segment. One more segment we are having, that is known as ST segment. तो PR segment is telling us about the AV nodal delay. AV nodal delay मतलब करंट कहाँ पर है, current is in the AV nodes, current is in the AV nodes. And what about this ST segment? ST segment is telling us about the, मतलब अभी क्या हो रखा है, complete ST segment is telling us about the ventricular depolarization. So complete ventricles are depolarized. Okay, एक बार ये समझ में आ गया, all these ECGs will be easy for you, right? Next thing we are having intervals. We are having like PR interval, PR interval. इंटरवल में क्या आएगी, दो चीज़ें आएगी। पी आर इंटरवल में क्या आ जाएगा बेटा, लुक हियर, पी आर इंटरवल इज द टाइम पीरियड फ्रॉम द स्टार्टिंग ऑफ पी वेव to the end of beginning of Q, right? So that is going to be your PR interval telling us about the complete atrial activity. This is going to tell us about the AV conduction कह सकते हो, या एट्रिया से वेंट्रिकल में कितनी देर में करंट जा रहा है, that is going to be your PR interval, PR interval, right? Next thing we are going to have is your QT interval. QT interval beginning of the Q wave till the end of the T wave. Q से लेकर T तक पूरी कहानी किसकी, ventricles की. Complete story of your ventricles is known as QT interval. We always study some drugs will do what, QT prolongation, QT interval. So QT interval is telling us about the complete ventricular activity. इसमें दोनों आगे, डीपोलराइजेशन और रीपोलराइजेशन दोनों आ गया, राइट। एंड लास्टली वी आर हैविंग आरआर इंटरवल, दैट इज व्हाट वी आर गोइंग टू स्टडी नेक्स्ट। आरआर इंटरवल क्या होता है, कैसे यूटिलाइज करना है, वी आर गोइंग टू स्टडी अबाउट दैट, राइट। सो दिस इज गोइंग टू बी द बेसिक्स। इसमें कोई डाउट है, इसमें कोई दिक्कत है, नो इश्यूज विद दिस, ओके। देखो, if you understand this particular thing, everything will be easy. Like now you have to tell me, okay, so this is a wave, let's say, let me ask you the question. So this is a wave, this is your P wave, right? And then we are having elongation of this is your PR, this is your QRS, and now T. What is this, what is this indicating? This is your P Q R S T. यहाँ पर क्या हो रहा है, here we are having what, AV nodal delay, AV nodal delay. So whenever you see such type of ECG, तो कहाँ दिक्कत आ रही है, suppose if I am talking about this heart, तो यहाँ करंट जनरेट हुआ, that is going to be your P, and this PR interval is prolonged. That means current is where, current is in the करंट इज इन द AV node. AV node के अंदर करंट डिले कर रहा है, यानी ये कौन सी डिजीज हो गई, दिस इज गोइंग टू बी योर हार्ट ब्लॉक, दिस इज गोइंग टू बी योर heart block. We also call it AV block, we also call it AV block. Drug of choice for this particular thing is going to be your atropine, right, atropine, right. One more case if I want to ask you, let's say this is your P, this is your P, just after the P we are not having the PR segment. PR segment की जगह क्या आ गया, there is another wave, ठीक है, there is another wave, and this wave is known as what, this wave is known as delta wave. Delta wave is seen in which syndrome, anyone, delta wave is seen in which syndrome? Yes, that is going to be your, that, very good, that is going to be your Wolff Parkinson White syndrome. Basically क्या हुआ यहाँ पर, normally current should go from this particular part, but now the current is taking aberrant pathways, re-entry mechanisms will be there, right? So what is going to happen, the current is taking the aberrant pathway. So what is going to happen, the current from the above chamber is directly going to the below chamber. तो यहाँ पर ये जो PR segment आना चाहिए था, ये नहीं आएगा, क्या हो जाएगा, डायरेक्टली आफ्टर जस्ट P there will be formation of what, there will be delta wave, और ये QRS directly आ जाएगा. You understand this? Very good, Mohit, Vrund, right? So that is going to be the thing, right? So in this particular case, our answer here will be, so this is a case, our answer in this particular case is going to be B. It is going to show us what, atrial depolarization plus AV nodal conduction, right? Now let's try to understand how to assess the हार्ट रेट कैसे कैलकुलेट करोगे? सो सिंपल अंडरस्टैंडिंग, हार्ट रेट कैलकुलेट करने के लिए वी आर हैविंग टू फॉर्मूलाज. वन इज गोइंग टू बी योर 300 डिवाइडेड बाय नंबर ऑफ लार्ज स्क्वायर, number of large squares, number of large squares, that is going to be your heart rate. Okay, second formula that we are having is going to be your 1500 divided by number of small square, number of small squares, number of small squares, right? So just look here, we are having this ECG, this is your basic ECG that we are having. Now try to understand. ओके यहाँ पर क्या है, 1 2 3 4 5 बॉक्सेज आर देयर, राइट? दिस पर्टिकुलर बॉक्स इज टेलिंग अस अबाउट द टाइम, राइट? एंड दिस इज गोइंग टू टेल अस अबाउट द एम्पलीट्यूड, हाइट के बारे में बताएगा, राइट? दिस पर्टिकुलर थिंग इज गोइंग टू टेल अस अबाउट द एम्पलीट्यूड. तो this particular single box is going to tell us about how much time is there. So that is going to be 1 millimeter box is going to tell us about the 0.04 second. 0.04 सेकेंड, एक बार को याद कर लो, काम आएगा आगे, राइट? सेकेंड थिंग वी आर हैविंग इज द एम्पलीट्यूड. दिस एम्पलीट्यूड, one box is going to be 1 mm and it is going to show us 0.1 millivolt of deflection, because we are going to study about a thing. Sometimes they ask you question, there is लो वोल्टेज ईसीजी, हाई वोल्टेज ईसीजी. तो क्या होता है लो वोल्टेज ईसीजी, क्या होता है हाई वोल्टेज ईसीजी, इसके ऊपर प्रीवियस ईयर क्वेश्चन है. सो यू नीड टू अंडरस्टैंड एक बॉक्स में कितना आ रहा है. एक बॉक्स 1 mm का होता है एंड इट विल बी हैविंग 0.1 मिली वोल्ट. 5 बॉक्स है तो 0.5 मिली वोल्ट्स. इधर अगर 5 बॉक्स दे रखें तो दैट विल बी 0.2 सेकेंड, राइट? सो दैट इज गोइंग टू बी योर टाइम पीरियड, दैट इज गोइंग टू बी योर टाइम पीरियड, राइट? ये एक बिग बॉक्स है and these are your small boxes, these are your small boxes, right? Now we will be looking like when do we call it a low voltage ECG, when do we call it a high voltage ECG. Let's try to understand. So we are going to look at the R wave. अगर R wave चेस्ट लीड्स के अंदर और लिम्ब लीड्स के अंदर दोनों के अंदर अलग होगा. अगर R wave 5 लेस देन 5 मिलीमीटर बॉक्स, 5 mm मतलब 5 बॉक्स से कम है इन द लिम्ब लीड्स, दैट इज गोइंग टू बी योर लो वोल्टेज ईसीजी. और अगर चेस्ट लीड की बात करूं तो 10 mm से कम है तो दैट इज गोइंग टू बी योर लो वोल्टेज ईसीजी, लो वोल्टेज ईसीजी, दैट इज गोइंग टू बी योर लो वोल्टेज ईसीजी, लो वोल्टेज ईसीजी. ओके, हाई वोल्टेज कब होगा? हाई वोल्टेज इन द केसेस ऑफ, high voltage in the cases of whenever we are going to have hypertrophy of the left ventricle or right ventricle, we are going to have high voltage ECG. Okay, so we are going to have hypertrophy. ओके, लो वोल्टेज कब होगा? जब सपोज योर हार्ट इज देयर और हार्ट के बाहर क्या है, पेरिकार्डाइटिस, देयर इज सम फाइब्रोसिस हैपनिंग, और हार्ट के बाहर क्या है, टैम्पोनाड हो रखा है, यानी पानी भरा हुआ है. तो व्हाट विल हैपन, द योर मशीन विल असेस लेस करंट. लेस करंट असेस करेगी तो क्या होगा, ये जो आर वेव है ये छोटी आएगी. आर वेव छोटी आएगी, दैट इज अ इंडिकेशन, दैट मीन्स वी आर हैविंग सम काइंड ऑफ पैथोलॉजी, राइट? लाइक इन द केसेस ऑफ कार्डियक टैम्पोनाड. कार्डियक टैम्पोनाड क्या होता है? कार्डियक टैम्पोनाड. सो सपोज दिस इज गोइंग टू बी योर हार्ट. हार्ट के चारों तरफ वी आर हैविंग पेरिकार्डियल सैक, इसके अंदर अगर फ्लूइड भर गया, वी आर हैविंग एक्यूमुलेशन ऑफ फ्लूइड हियर, सो दैट इज गोइंग टू बी योर कार्डियक टैम्पोनाड. अगर यहाँ पर ईसीजी असेस करोगे, व्हाट विल हैपन, यू विल बी हैविंग लो वोल्टेज ईसीजी. यू अंडरस्टैंड व्हाट इज लो वोल्टेज, व्हाट इज हाई वोल्टेज ईसीजी. सेकेंड थिंग अबाउट द हार्ट रेट, हाउ टू कैलकुलेट हार्ट रेट, you will be checking for the number of large boxes, number of small boxes, right? So let's say between 2 RR interval, right? Between 2 RR interval, between 2 RR interval, very very important. Look here, so ये एक R है, दूसरा R है, right? Between 2 RR interval we are having 2 boxes, so 300 divided by 2, here the heart rate will be approximately around 150, here 150, right? Here the heart rate will be 100. 300 divided by 3 boxes, 1 2 3 boxes. So we are going to, how we are going to assess the heart rate, क्वेश्चन है इसके ऊपर FMG में, right? We need to calculate the heart rate. तो any formula you can use, you just need to count the large boxes, 1 2 3 4. 300 divided by 4, that would be your approximately around 75 bpm, that is going to be your heart rate, that is going to be your heart rate. Now you know how to calculate heart rate, right? Next question they ask you is about the axis of ECG. Next question they ask you about the axis. Axis कैसे identify करेंगे? Axis के लिए what we need to know, So here also we are going to see the R wave. कौन सी wave देखोगे? R wave देखोगे. अगर first of all we need to understand the normal axis. Normal axis क्या होता है? यहाँ से लेकर अगर इस चीज़ के अंदर कोई भी चीज़ फॉल कर रही है, यानी -32 + 90, इफ समथिंग इज फॉलिंग, तो ये क्या हो जाएगा? नॉर्मल एक्सिस ईसीजी हो जाएगा. नॉर्मल एक्सिस किधर होती है? नॉर्मली वेक्टर किधर आना चाहिए? इधर आना चाहिए. अगर ये नॉर्मल वेक्टर इधर नहीं आ रहा, सपोज इधर आ रहा है, दैट मीन्स व्हाट इज हैपनिंग हियर? वी आर हैविंग हाइपरट्रॉफी. देखो सिंपल सी अंडरस्टैंडिंग है. ईसीजी मशीन इज गोइंग टू असेस द करंट, राइट? और करंट कहाँ फ्लो कर रहा है? विद इन द हार्ट. जहां पर भी ज़्यादा करंट फ्लो करेगा उधर की साइड क्या आ जाएगा? वेक्टर ज़्यादा आ जाएगा, उधर की साइड मूवमेंट ज़्यादा हो जाएगा. इफ समवन इज हैविंग राइट वेंट्रिकुलर हाइपरट्रॉफी, व्हाट इज गोइंग टू हैपन? ही विल बी हैविंग मोर करंट ऑन दिस साइड, दिस पर्टिकुलर साइड. मसल ज़्यादा है, डिपोलराइजेशन ज़्यादा होगा, करंट ज़्यादा होगा, यू विल बी हैविंग राइट वेंट्रिकुलर हाइपरट्रॉफी, राइट? सो नॉर्मली इट शुड बी लाइंग बिटवीन दिस पर्टिकुलर थिंग. कैसे असेस करोगे? टू थिंग्स यू हैव टू सी. फर्स्ट थिंग यू हैव टू सी इज द लीड नंबर 1. सेकेंड थिंग यू हैव टू सी इज द AVF. देखो अगर लीड नंबर 1 और AVF दोनों पॉजिटिव आ रहे हैं, both the things are positive, lead number 1 and AVF, both the things are positive, that means somewhere the vector will be lying on this particular direction, right? अगर सिम नहीं भी याद हो रहा, सिंपल याद रख लो, दोनों पॉजिटिव है, नॉर्मल एक्सेस, दोनों पॉजिटिव है, नॉर्मल एक्सेस, राइट? सेकेंड थिंग, अगर लीड 1 पॉजिटिव है, लीड 1 इज पॉजिटिव बट लीड AVF is negative, this one is positive but this one is negative, it is going to go in the left axis deviation, left axis deviation हो जाएगा, राइट? अगर ये वाला नेगेटिव है, लीड 1 इज नेगेटिव एंड लीड AVF is going to be positive, that is going to show us somewhere here, that is going to be your right axis deviation, right axis deviation. और दोनों अगर नेगेटिव आ रहे हैं, that means it is a extreme axis deviation जो इस डायरेक्शन में आएगा, that is going to be the extreme axis deviation. Let's try to understand कैसे इसको understand करने. So look here, this is your lead 1, this is your lead 1, it is showing you R wave. R wave कैसी आ रही बेटा? यहाँ पर R wave is negative in the lead 1. Look here, AVF is negative और positive. Negative positive मतलब ये ऊपर जा रहा है या नीचे जा रहा है? नीचे जा रहा है मतलब negative, ऊपर जा रहा है मतलब positive. So first lead is going to be negative and AVF is positive. Now you tell me, what is the axis deviation here? This is going to be what? This is going to be which deviation here? Try to answer. So first lead is going to be negative, first lead is negative, right? And second lead is positive, so this is going to be right axis deviation. This is going to be your right axis deviation, right axis deviation. Now try to tell me this one. First lead is going to be positive, first is positive here. Can you appreciate the positive R wave, right? And here in the AVF we are going to have a negative R wave, right? AVF we are going to have a negative R wave. Okay, so first lead is positive and AVF is negative. Okay, first lead is positive, AVF is negative, that is going to show us about the possibly it is going to be a left axis deviation. It is going to be left axis deviation. Very good Mohit, it is going to be your left axis deviation. So इस टाइप के क्वेश्चन आते हैं, you just need to understand this. एक दो बार इसको बनाना है, एक दो बार इसको बना लोगे ऑटोमेटिकली समझ में आ जाएगा, you will get to know how to make this. Okay, या फिर conceptually इसको भी याद कर सकते हो. Okay, so this is how you are going to understand the ECG axis. Okay, so what we understood, how this ECG is going to form. Second thing, we have understood how this particular RR interval we are going to count and how this axis we are going to determine, right? So now try to solve this particular question. A 49-year-old male patient is presented to the emergency. एक patient emergency में आ रहा है with the symptoms of, what are the symptoms this patient is having? Symptoms of palpitation. This patient is having palpitation बेटा. Dyspnea मतलब difficulty in breathing and tightness in the chest. Tightness in the chest will be there. On examination we are having irregular pulse. Okay, irregular pulse. हम उसकी pulse check कर रहे हैं and we are finding this particular patient is having irregular pulse and the ECG of this particular person is shown below and this is the ECG we are having here, right? So is it your Wolff-Parkinson-White syndrome? Is it your atrial fibrillation, Mobitz type 1, bundle branch block? What is this? So first of all, how to assess a ECG? First of all, look at the P wave. Here P wave is absent. You cannot find the P wave in this particular ECG. P wave is going to be absent. Second thing is going to be your QRS. Look here, QRS, नॉर्मल QRS कितना होता है? यू हैव टू रिमेंबर दिस नॉर्मल QRS. अगर ये छोटी छोटी चीज़ें याद हो गई, ECG पढ़ना बिल्कुल आसान हो जाएगा, राइट? इट विल बी वेरी वेरी ईजी, इट विल बी अ जस्ट अ piece of cake for you, right? So that is going to be 2 to 2.5 small square. 2 to 2.5 small square is going to be the normal QRS. छोटे स्क्वायर देखो इधर. So this is going to be 1, 2 और 2.5. अगर ये 2 to 2.5 के बीच में, that is going to be pretty normal. It is going to be normal. अब इससे ज़्यादा होगा तो हमको डिजीज सस्पेक्ट करना है QRS वाला, अदरवाइज इट इज़ नॉर्मल. तो दो चीज़ें यहाँ पता चली. फर्स्ट थिंग, P wave is absent. Second, QRS is normal. Now let's try to understand what is this QRS is going to tell us. Okay, so I'm just making a flow chart so that you can remember it easily. So whenever you are going to have narrow QRS मतलब क्या हो गया, या 2 या 2.5 से कम हो. whenever you are going to have narrow QRS, you will be suspecting the cause in the atria, the problem in the atria. And what are the problems you can have? You can have sinus tachycardia. The problems sinus tachycardia हो सकता है. You can have PSVT, paroxysmal supraventricular tachycardia. You can have atrial flutter. You can have atrial fibrillation. So these are the possibilities we can have, right? जब भी narrow QRS complex मिलेगा, कितना narrow? Less than 2 to 2.5 small square. और you can remember the value also, 80 to 100 millisecond और 0.8 to 1 सेकेंड, 0.8 to 1 सेकेंड. तो अगर इससे कम QRS दिख रहा है, कहीं पर भी कम QRS दिख रहा है, दैट मीन्स प्रॉब्लम कैन बी एनी ऑफ देम. प्रॉब्लम कैन बी साइनस टेकिकार्डिया, PSVT हो सकते हैं, एट्रियल फ्लटर हो सकता है, एट्रियल फिब्रिलेशन हो सकता है, राइट? ब्रॉड QRS कॉम्प्लेक्स कहाँ दिखेगा? ब्रॉड QRS अगर ये ज़्यादा दिख रहा है, 2.5, 3, 4, 5, राइट? अगर ये ब्रोड दिख रहा है, दैट मीन्स कॉज इज गोइंग टू बी प्रेजेंट इन वेंट्रिकल्स. तो यहाँ पर अगर ये 1 सेकेंड से ज़्यादा टाइम दे रखा है, या मोर देन 100 मिली सेकेंड दे रखा है, राइट? अगर मोर देन 3 स्क्वायर दे रखा है, 3 small square, that is going to be, cause is going to be present in the ventricles. And what are the causes? Ventricular tachycardia हो सकते हैं, ventricular fibrillation हो सकता है. Ventricular tachycardia can be there, ventricular fibrillation can be there, right? So narrow complex में sinus tachycardia, PSVT, atrial flutter, atrial fibrillation. Okay, broad QRS में it can be VT, it can be VFib, right? So now let's try to understand what is the meaning of a rhythm, right? Tachycardia is a different thing. Tachycardia is a different thing, tachyarrhythmia is a different thing, right? So normal sinus rhythm क्या होती है और फिर sinus arrhythmia क्या होता है? Let's try to understand this. So first of all we are having this P, then QRS and then T. अगर P के बाद में QRS complex और T पूरा आ रहा है, that is going to be your sinus rhythm. इनके बीच में गैप देखो, look here, half, 1, 2, 3 and 3.5, that is going to be the same. RR इंटरवल दोनों के बीच में क्या आ रहा है? इन सब के बीच में RR इंटरवल अप्रोक्सीमेटली, ऊपर से भी देखोगे तो क्या लग रहा है? सेम लग रहा है. RR इंटरवल इज सेम. ओके, सो दैट मीन्स अगर इक्वल टाइम है हार्ट बीट्स में, दैट इज नॉन एज साइनस रिदम, नॉर्मल साइनस रिदम. अरिथमिया क्या होता है? अरिथमिया कब होता है? लुक हियर, नाउ वी आर हैविंग चेंजेस इन द RR इंटरवल. कैन यू अप्रिशिएट? यहाँ थोड़ा ज़्यादा है, यहाँ कम है, यहाँ कम है, यहाँ फिर ज़्यादा है, राइट? सो अनइक्वल टाइम बिटवीन द हार्ट बीट्स, दैट इज नॉन एज अरिथमिया, तो ये अरिथमिया हो गया, राइट? नाउ वी आर हैविंग दिस साइनस टैकीकार्डिया मतलब, नाउ वी ऑलरेडी नो, लुक हियर, how many boxes will be there between RR interval? So you can appreciate, one is here, so we are having 1 2 1 2 1 2, right? So 2 boxes. What is the heart rate here? What is the heart rate? Heart rate कैसे निकालेंगे? 300 divided by number of big boxes, that is going to be approximately around 150 heart rate है, that is known as sinus tachycardia. sinus क्यों बोला? P है सर, QRS है, TB है, P है, QRS है, TB है. दूसरी चीज़ ये देखो, QRS कॉम्प्लेक्स क्या नैरो हुआ? यस सर, QRS कॉम्प्लेक्स इज गोइंग टू बी नैरो हियर. सो दो चीज़ें पता चल गई. यहाँ पर क्या पता चला? एक तो हार्ट रेट कम है और दूसरा नैरो QRS कॉम्प्लेक्स. नैरो QRS कॉम्प्लेक्स मतलब 4 प्रॉब्लम हो सकती थी. फर्स्ट इज योर साइनस टेकिकार्डिया, दैट इज व्हाट वी आर लुकिंग हियर, राइट? सो दिस इज द केस ऑफ साइनस टेकिकार्डिया. कैसे ट्रीट करोगे? हार्ट रेट ज़्यादा है, you can do carotid massaging, you can use drugs like beta blockers. Beta blockers दे दोगे, that is going to treat your sinus tachycardia. I hope you understand this, right? How you will see the sinus bradycardia? So you will be having this P QRS T, again P QRS T, but look here, is it regular or irregular? Rhythm is regular or irregular? You can calculate, even you can see there is equal distance between two RR waves. Equal distance is there, equal distance is there, right? So it is a sinus rhythm which is regular rhythm, right? So now count the number of boxes: 1 2 3 4 5 6. Six boxes are there, right? So 300 divided by 6, that is going to be approximately around, okay, 50, right? So here the heart rate is around 50. This is known as sinus bradycardia. How you will treat this situation? Whenever you are going to have this bradycardia, you are going to give a drug that is going to be your atropine. That is going to be your atropine is the drug of choice here, right? Now how you will identify the PSVT? How you will identify the PSVT? First thing, look here, can you appreciate the QRS complex is narrow here, right? Can you appreciate the QRS complex is narrow here, right? So we are having, first thing, narrow QRS complex, narrow QRS complex. Heart rate is going to be around, you can calculate heart rate, it is going to be 1.5 square, 1.5 you can calculate, or if you just divide it by 1 also, you will be getting heart rate around approximately 150 180 heart rate. So heart rate will be here in this particular case around 180 to 200, 180 to 200 के आसपास हार्ट रेट रहेगी, right? And next thing, P will be absent. P and T are going to be merged. P and T are going to be merged together. Look here. So what is going to happen? This is your normal sinus rhythm. P, Q, R, S, T, everything was fine. Now what is happening? Now there is loss of P. Then this P and T are merging together. P and T are merging together. Narrow QRS complex. P and T are merging together. Narrow QRS complex. That is going to be the ECG for PSVT. Okay. Regular है, irregular है यहाँ पर rhythm. Rhythm will be regular, beta. Rhythm will be regular. Okay, so that is going to be the diagnosis of PSVT. PSVT के ऊपर क्वेश्चन आता है, अगर ये स्टेबल है, अगर पेशेंट स्टेबल है, if the patient is stable, what we are going to do? We are going to do, first thing is going to be your carotid massage. Carotid massage फिजियो में पढ़ाया था, how it is going to work. So first thing is going to be कैरोटिड मसाज विच इज़ अ बैरो रिसेप्टर. वो क्या करेगा? हार्ट रेट को कम कर देगा. अगर कैरोटिड मसाज से भी कम नहीं हो रहा है, इफ इट इज़ नॉट डिक्रीजिंग बाय कैरोटिड मसाज, द ड्रग ऑफ चॉइस इन PSVT, ड्रग ऑफ चॉइस इन PSVT, व्हाट इज द ड्रग ऑफ चॉइस? दैट इज गोइंग टू बी योर IV एडिनोसिन. IV एडिनोसिन इज गोइंग टू गिव द, हम एक पुश कर देंगे IV एडिनोसिन का, दैट इज गोइंग टू बी द ड्रग ऑफ चॉइस. इफ द पेशेंट इज अनस्टेबल, if the patient is unstable, we need to give the DC shock to the patient. We are going to give synchronized DC shock to the patient. DC cardioversion हम लोग patient का करेंगे. And synchronized का मतलब क्या हो गया? Whenever we are going to give the current on the R wave, जब भी R wave दिख रही है, shock we are giving on the shock on R wave, that is known as synchronized DC shock. अगर R wave नहीं दिख रहा है और हम shock दे रहे हैं, that is known as desynchronized. Okay, so that is going to be synchronized DC shock of 200 joules we are going to give, and now the patient, the rhythm will be restarted. Restart हो जाएगा सब कुछ, right? So that is going to be the thing. Now try to identify this ECG. What we are looking at here in this particular ECG, what we are looking. So this is your P wave, this is your QRS, this is your T, right? Can you appreciate we are having loss of PR segment, right? We are having a delta wave here. So we are having a delta wave here. Delta wave is present. And why this delta wave is present? Because of bundle of Kant. Previous year question, bundle of Kants are involved here. Okay, bundle of Kants are involved. Here we are going to have short PR interval and delta wave will be there. शॉर्ट PR इंटरवल पूरा छोटा हो जाएगा. लुक हियर, राइट? PR इंटरवल यहाँ से छोटा हो जाएगा. दैट इज गोइंग टू बी शॉर्ट PR इंटरवल. ओके, हाउ यू आर गोइंग टू ट्रीट दिस? Why this is happening? This thing is happening because of aberrant pathway. You can remember, this is happening because of aberrant pathway. aberrant pathway, extra pathway बन गया between atria and ventricles. Normally everything should be coming with the help of AV node, but now what is happening, we are having extra pathways, extra nodal pathway, aberrant pathways, right? So now how we are going to treat the patient? Agar patient stable, if the patient is stable, we are going to give the drugs like procainamide or flecainide, procainamide or flecainide. We are going to use drugs like procainamide or flecainide. If the patient is unstable, we are going to give synchronized DC shock. We are going to give what? Synchronized DC shock. Synchronized DC shock to the patient. This is what is going to restart the rhythm, right? So that is going to be the thing, right? And what is the treatment of choice, beta? Treatment of choice is going to be your radio frequency ablation. Radio frequency ablation of the aberrant pathway, that is going to be the treatment of choice, right? So now we understand what is PSVT, what is Wolff-Parkinson-White syndrome, right? Next thing we are going to discuss is going to be your this particular wave. Okay, this particular wave. Okay, can you appreciate the QRS complex is narrow, like 2 to 2.5 squares, right? Second thing, can you appreciate P wave or T wave, right? You're not able to appreciate. Look here, what is this? This is a sawtooth wave pattern seen in the atrial flutter. It is characteristic of what? Atrial flutter, right? So here you will be having sawtooth wave pattern. Sawtooth pattern will be there. What is going to be the heart rate in this particular case? If you want to calculate the heart rate, that is going to be approximately around 150. Okay, two boxes are there, so that would be approximately around 150. 300 divided by 2, that is going to be 150, right? Why this thing is happening? This thing is happening due to macro reentrance pathway. This thing is happening because of macro reentrance pathways. In this particular case, can you appreciate the rhythm is regular? The rhythm is regular. Here the rhythm is regular, right? So very, very important to understand. Rhythm is going to be regular here. Rhythm is going to be regular here. And what about the P wave? P wave is going to be absent. Okay, so for the treatment of this atrial flutter, what you are going to do for the treatment, you should be controlling the rhythm first. We should be controlling the rhythm here, and how we can control that with the help of drugs like ebutilide or amiodarone, right? Amiodarone or ebutilide are the drugs. Ebutilide and amiodarone are the drugs which are like class 3, right? And antiarrhythmic drugs, like we are having 5 classes of antiarrhythmic drugs. I'm going to make you summarize how and when we are going to utilize all these drugs, right? So that is going to be your ebutilide. If it is not corrected with the ebutilide, then again restart everything, right? Restart means you can give the DC shock again. But remember here the DC shock you are going to give, that is your PYQ, 25 to 50 joules you are going to give. That is going to be your 25 to 50 joules, right? The next ECG that is in front of you, can you appreciate the P wave here? Right, you are not able to identify. Can you appreciate the T wave here? Right, you are also not able to identify that, right? So what is going to happen here? We will be having atrial fibrillation. This is the streak of atrial fibrillation. What happens with the QRS? If you want to see from the perspective we have studied, right? So what happens with the QRS? Sir, QRS is narrow. That means problem lies where? Problem lies above the AV node. That means problem is in the atrias, right? What can happen in the atria? Sinus tachycardia we have seen. We have already seen the PSVT. We have seen the atrial flutter. Last one that we are having is going to be your atrial fibrillation, right? So what is going to happen in that atrial fibrillation? You will be having this oscillating waves. You are not able to identify the P wave. P wave will be absent in two cases. First one is here in the flutter. But can you appreciate the rhythm here is going to be regular, right? While the rhythm here is irregular. Can you appreciate the rhythm is irregular here, right? And that is what we are having. So you will be having irregularly, very, very characteristic, irregular rhythm. irregular rhythm will be there. And why this thing is happening? Because normally the current should produce from the SA node, but now the current is producing from multiple ectopic foci. ectopic pregnancy पड़ा है, ectopic मतलब जहाँ होना चाहिए वहाँ नहीं है, कहीं और है, right? We are having, so we are going to have what? We are going to have multiple ectopic foci. We are going to have multiple ectopic foci. Ectopic foci will be there, right? Now how you will treat this particular situation? For the treatment, if the patient is stable, agar patient stable hai, we are going to give the DC shock to the patient. And the drugs that we are going to use, again we can use amiodarone or ibutylide, right? So the drugs will be, drugs that we are going to use is going to be your ibutylide, right? But if the patient is unstable, we need to manage it with a different thing, right? अगर patient unstable है, so first of all we want to control the rate of the patient, so we are going to give beta blockers to this particular patient. We are going to use what? Beta blockers. Beta blockers are going to control the rate. First of all, we are going to control the rate, right? Beta blockers, like we can use short acting, that is your esmolol or metoprolol, right? Second thing, we are having a risk, that is why we just want to decrease the coagulation, right? So we are going to give what? Anticoagulant drugs like warfarin, right? And lastly, we are going to do the control of the rhythm, that is going to be your rhythm control. Again, rhythm can also be controlled with the help of like beta blockers. We can also use CCBs, calcium channel blockers, right? So this is going to be the management for atrial fibrillation. Atrial fibrillation, very, very important, right? So now what we have understood, अगर नैरो क्यूआरएस कॉम्प्लेक्स है, नैरो क्यूआरएस कॉम्प्लेक्स है, नैरो मतलब 2 या 2.5 बॉक्सेस से कम है, सो वी कैन हैव दीज पॉसिबिलिटीज, वी कैन हैव दीज पॉसिबिलिटीज. व्हाट आर दीज पॉसिबिलिटीज? वी कैन हैव साइनस टैकीकार्डिया, वी कैन हैव PSVT, we can have atrial flutter, we can have atrial fibrillation. The drug of choice here, that is going to be your adenosine, right? Sinus tachycardia, beta blocker दे दोगे. Flutter we have seen 25 to 50 joules. We are going to do DC cardio version. And atrial fibrillation, we are atrial fibrillation also we are going to do the DC cardio version, and this particular things, right? So that is the narrow QRS complex problems, right? Now we are going to discuss about the problems in the ventricles. Now we are also having the problems in the ventricles. So what I've taught you, if there is problem in the ventricle, what is going to happen? You will be having broad QRS complex. Broad QRS complex will be there. Broad मतलब more than 1 second या more than 100 millisecond or more than 2.5 small squares. More than 2.5 small squares, that would be your problem with the broad QRS complex. So first problem that we are going to have over here, can you appreciate the P wave in the first ECG? Can you appreciate the P wave in the first ECG? Is it regular or irregular? Okay, so P wave is going to be absent. First thing, P wave is going to be absent. Second thing, broad QRS complex. Can you appreciate? This is your broad QRS complex. Normally it should be between what? It should be between 2.5 squares, right? Now what is happening? It is very big. It is very big. It is covering more number of boxes, right? So it is a broad QRS complex, and this is a case of monomorphic VT. Here the rhythm is going to be regular. Rhythm is going to be regular, right? So what we are going to do for the treatment of this particular thing? ट्रीटमेंट कैसे करोगे? वेंट्रिकल्स आर इंपॉर्टेंट. वेंट्रिकल्स आर पंपिंग द ब्लड टू द बॉडी. एट्रियाज आर नॉट सो इंपॉर्टेंट. वेंट्रिकल्स ज़्यादा इंपॉर्टेंट है, राइट? वेंट्रिकल्स कैन कॉज डेथ ऑफ द पेशेंट, राइट? सो व्हाट इज गोइंग टू हैपन इफ द पेशेंट इज स्टेबल? If the patient is hemodynamically stable, we are going to use a drug that is going to be antiarrhythmic drug, that is going to be amiodarone. Amiodarone. Okay, this thing can happen post MI also. Post MI patients में हम लोग क्या करते हैं बेटा? Post MI patient we are going to give what? Lidocaine. Post MI we are going to use what? Lidocaine. Okay, if the patient is unstable, अगर पेशेंट अनस्टेबल है, सो व्हाट वी आर गोइंग टू गिव? अगेन रीस्टार्ट करना है. रिदम खराब हो रही है, वी नीड टू रीस्टार्ट. सो फॉर रीस्टार्टिंग वी नीड टू गिव व्हाट? DC shock. Now we are going to give what kind of DC shock? It is going to be biphasic. it is going to be biphasic, and it is going to be desynchronized because we are not able to find the R wave, right? So this is going to be desynchronized DC शॉक. एट्रिया में हम लोगों ने क्या दिया था, सारे शॉक आर वेव के ऊपर दिए थे, दैट इज सिंक्रोनाइज शॉक. हियर वी आर हैविंग डीसिंक्रोनाइज्ड बाइफेजिक डीसी शॉक, राइट? दैट इज व्हाट वी आर गोइंग टू गिव, राइट? अगर सारी मॉर्फोलॉजी सेम है, ऑल द मॉर्फोलॉजीज आर सेम, दैट इज नॉन एज मोनोमॉर्फिक वेंट्रिकुलर टेकिकार्डिया, राइट? अगर मॉर्फोलॉजीज डिफरेंट अगर morphology is different है, we are having this different morphology, different amplitude. Here we are having this oscillatory मतलब change होता हुआ oscillatory. Here we can see oscillatory changes. Here we can see oscillatory changes, and this is not a monomorphic. Can you appreciate the waves? Waves are different, right? So this is showing you oscillatory changes in the amplitude. Right? What happens with the QRS complex is definitely going to be broad, right? And this TDP, torsade depointes, is associated with the QT prolongation also. QT prolongation. Certain drugs can also cause this QT prolongation, right? And what is the drug of choice for torsade depointes? That is going to be your magnesium sulfate, MgSO4. That is going to be your magnesium sulfate. That is going to be the drug of choice, and this is your torsade depointes. This is your torsade depointes, right? This is a type of ventricular tachycardia itself, right? Now what is happening in this particular ECG? Can you appreciate QRS or something, P wave, QRS, T? Okay, here there is no P, here there is no QRS. You are not able to identify the T as well, right? So all of them are going to be absent. There is only a chaotic rhythm is there, right? And this rhythm is, remember, shockable. This rhythm is shockable rhythm, right? So हम लोगों ने कल पढ़ा था, in the last class we have discussed cardiac arrest. And cardiac arrest बंदा, I have taught you a question, जो एक there is uncle who was jogging on the park, वो park में सो गए थे, right? He is having the cardiac arrest. Now it is a shockable rhythm. When you are going to attach the AED, automatic external defibrillator, what is going to happen? It is having the option DC shock देना है, तो DC shock कब देना है? Whenever you are having shockable rhythm, वो automatically decide करेगा. You just need to press it, right? So that is going to be a shockable rhythm, and this particular ECG is the ECG for ventricular fibrillation. इसके बाद में क्या होता है? इसके बाद में ये ECG ऐसे होती ultimately this ECG will convert into a flat line, and flat line means you already know there is no electrical activity. मतलब कहानी खत्म, right? Basically the story is over, right? So that is going to be the broad QRS complex. These are the basic thing that you need to understand, right? Identify कर लोगे, you can easily identify now, right? So what is going to be your answer in this particular case? Try to identify this ECG. Is it Wolff-Parkinson-White syndrome? Is it your Wolff-Parkinson-White syndrome? No sir, there will be delta waves. Is it your atrial fibrillation? Yes sir, it is your atrial fibrillation. Why? Because sir, P wave is absent, rhythm is irregular, right? The pulse is irregular. That is what is given in the question itself. Patient is going to have what? Palpitation. Patient is going to have what? Dyspnea and tightness in the chest, right? These are going to be the symptoms. Morbid's type 1, what should be happening? There will be problem with the PR interval, PR segment में problem होना चाहिए था. That is going to be a type of heart block, right? Bundle branch block, there will be different waves that we will be discussing, right? So in this particular case, the answer will be B. Very good guys. Now try to solve this particular question. A 57-year-old male patient is presented to the emergency with the symptoms of weakness in the muscle. Very important question. Weakness in the muscle. Dyspnea is there. Oliguria is there. Patient is not able to urinate very well, right? Oliguria मतलब कितना urination हो रहा है? Polyuria मतलब कितना हो रहा है? Oliguria मतलब कितना हो रहा है within a day, right? On examination we found that he was on eplerenone therapy. What is this eplerenone? Anyone? Right? And having hypotension and bradycardia. Now this patient is having what? Hypotension and bradycardia. Hypotension is there, bradycardia is there. The ECG was ordered and given below. How will you manage this particular patient? So this is a case where you are able to see which kind of waves. First of all, weakness in muscle is there, dyspnea is there, right? Oliguria is there. There is problem with the urination. Oliguria मतलब less than 400 ml. Oliguria मतलब कम यूरिन आ रहा है, less than 400 ml. Polyuria more than 3 liters. More than 3 liters will be polyuria, right? Anuria मतलब उससे भी कम हो गया, right? Apleronone is a what? It is a potassium sparing diuretic. Apleronone, spironolactone is a potassium sparing diuretics, and you already know potassium sparing diuretics. So what it will be doing, it will be sparing the potassium, it will be increasing the potassium, it will be increasing the potassium, right? And whenever we are going to have more and more potassium, what is going to happen, we are going to have this P, this is your neuro QRS, right? And we are going to have this tall tented T waves. Can you appreciate this tall tented T waves, right? So this tall tented T waves are the symptoms of hyperkalemia. You are going to find these waves in the hyperkalemia, right? And what is the thing you should be knowing? Hyper or hypokalemia ka cutoff kya hai? What is the cutoff, right? So 3.5, below 3.5 will be hypokalemia, and more than 5.5 milliequivalent per liter, that is going to be your hyperkalemia. This is a narrow range you have to maintain, right? इससे नीचे जाएगा, if it is going below 3.5, that is going to cause symptoms of hypokalemia, whereas if it is going above 5.5, that is going to cause symptoms of hyperkalemia, right? So for the treatment of hypo and hyperkalemia, what is the drug that you would like to use over here? Is it your adrenaline, noradrenaline, cardioversion, or would you like to use calcium gluconate? Very good, Sheikh, Mohit, Kingdom, right? All of you are answering D, right? Let's try to understand what is this thing and how we are going to manage that. Hypo and hyperkalemia, very, very important topics, right? So for treatment, they are asking question, right? Look here. First thing, whenever we are going to have normal potassium, you will be having P, QRS, and T. Normal waves will be there, right? Now what is going to happen, whenever we are going to have hyperkalemia or hypokalemia, the waves will be changing, right? So what are the changes we are having in the hyperkalemia? Look here, P will be there, QRS will be there, and there will be peaking of the T wave. There will be first change, that is going to be your peaking of T wave. There will be peaking of T wave. T wave will be increased, right? Then what is going to happen, you will be having second thing, that is going to be on the PR interval. Can you appreciate this? PR interval is going to increase. There will be increment in the PR interval. Here what is happening, look here, we are having increasing the levels of potassium, 5.5 से ज़्यादा होता जा रहा है potassium, and what are the changes we are going to have, like we are looking at that, right? Here what is happening, here we are going to have the duration of QRS is increased, so QRS duration will be increased, right? And ultimately what is going to happen, there will be loss of P wave, and what is this particular pattern is known as, along with that we are also having this ST elevation, right? So this is what is important whenever you are having hyperkalemia. Hyperkalemia can lead to ST elevation. Hyperkalemia is a detrimental situation, so we need to know how to manage this particular thing, right? So इसका treatment पता होना चाहिए. Treatment के ऊपर we are having questions. So acute cases we are going to treat it. First of all, we are going to give what? We want to maintain our heart cells or heart muscles, right? So for maintenance we are going to give what? IV calcium gluconate. This IV calcium gluconate is going to do what? It is going to stabilize your myocardium. Second thing we are going to do, we want to decrease the levels of potassium. So what are the things you know by your pharmacology knowledge? Tell me, what are the things which are going to decrease the levels of potassium? पोटेशियम किससे डरता है? देर आर सर्टेन थिंग्स, राइट? सो फर्स्ट थिंग वी आर हैविंग इज इंसुलिन जैसे ही बॉडी में अंदर आएगा पोटेशियम भाग जाएगा अंदर, सेल के अंदर चला जाएगा, राइट? सो फर्स्ट थिंग वी आर हैविंग इंसुलिन, एंड व्हाट इज द ओनली इंसुलिन दैट वी कैन गिव IV? Yes beta, that is going to be your regular insulin. So we are going to give here regular insulin to the patient, right? Along with the regular insulin we need to give what? Insulin देंगे, there will be hypoglycemia, so we need to manage the hypoglycemia. So we are going to give what? Dextrose to the patient. Dextrose मतलब sugar साथ में दे दिया, right? So that is going to maintain. Second thing, we are having beta 2 agonist drugs like salbutamol, right? So we can do the nebulization of salbutamol. Salbutamol is also causing what? Salbutamol is also causing the potassium is going inside the cell because of salbutamol, right? Third thing, we are going to have what we are having if this patient is taking long term like aplerenone, what is going to happen? This aplerenone is going to work here, right? This aplerenone is a aldosterone receptor blocker. The aldosterone will be coming, and this aldosterone will be working on ENAC channels. Let me brush your concept. ENAC channels will be there, potassium channels will be there, and H plus channels will be there, right? So what this aplerenone is going to do, aplerenone is going to do, it is going to block this particular thing, right? Sorry, this aplerenone is going to block this particular enzyme, right? ENAC बंद हो गया, ENAC बंद हो गया तो क्या होगा? What is going to happen? There will be loss of, there will be loss of potassium, there will be there will be loss of sodium, loss of sodium. ये क्या बन रहा है? This is your urine, right? This is your urine which is going away, right? And we are having this pump. This ENAC channel has a function, इस epithelial sodium channel है, सोडियम को अंदर लेंगे, सोडियम के साथ में हमेशा क्या जाएगा बच्चों? वाटर जाएगा. सो वी विल बी हैविंग एक्यूमुलेशन ऑफ सोडियम एंड वाटर इन द बॉडी, फ्लूइड ओवरलोड बढ़ेगा, राइट? और सोडियम और वाटर अंदर जाएगा तो ये क्या करता है? पोटेशियम और H प्लस को बाहर फेंकता है, राइट? नाउ व्हाट इज हैपनिंग? वी आर ब्लॉकिंग दिस पर्टिकुलर पंप. इसको बंद कर दिया, व्हाट विल हैपन? पोटेशियम विल accumulate inside the body, hyperkalemia will be there, as well as this H plus is also going to retain in the body. That is going to lead to what? Metabolic acidosis. So metabolic acidosis अगर component है, so we are going to give what? Sodium bicarbonate in this patient. Sodium bicarbonate अगर acidosis present है, if acidosis is there, okay, this is your NEET PG question. They are asking this particular question. Agar acidosis present a component, then we are going to give what? We are going to give this particular thing, that is going to be your sodium bicarbonate, right? What are the different causes we are going to have? What are the different causes we are having? Like those people who are taking spironolactone, eplerenone, those things which are going to increase the potassium in the body, they are going to be the causes, right? Now let's try to understand about the hypokalemia. What is going to happen in the hypokalemia? This is your P, narrow QRS, T, and now this T wave start to shrink whenever there is hypokalemia. Hypo में क्या होगा? T wave श्रिंक होने लग जाएगा, और टी वेव श्रिंक होने के बाद में क्या होगा? यू वेव बनेगा, यू वेव विल बी देयर, राइट? सो देयर विल बी फ्लैटनिंग ऑफ द टी वेव्स. व्हाट आर द कॉजेज ऑफ हाइपोकैलेमिया? व्हाट आर द कॉजेज ऑफ हाइपोकैलेमिया? Hypokalemia can be due to dehydration. It can be due to dehydration. It can be due to alkalosis. It can be due to certain drugs which are going to cause hypokalemia, right? We are having different drugs, right? So in ECG you will be finding T wave inversion. T wave inversion होगा. T wave flattening will be there, leading to inversion, right? और उसके अलावा क्या आएगा? You will be having this U wave plus U wave appearance will be there. U wave start to come, right? So this is going to be your hypokalemia. How you are going to treat this particular situation? How you are going to treat hypokalemia के ट्रीटमेंट के लिए क्या करोगे? पोटेशियम दे दोगे, that is going to be your potassium chloride, right? We can use oral potassium chloride, that is going to be the treatment. बनाना खिला दो पेशेंट को, right? Also you have to remember one more thing. Right? What you need to do? Remember, it can cause torsade de pointes. So you need to check on magnesium also. So also look for magnesium. You need to keep an eye on magnesium also, right? That is also a question. So अगर इसके बाद भी improve नहीं हो रहा है, you need to look for magnesium as well, right? Magnesium is the drug we are going to give in the cases of torsade de pointes, MgSO4, right? That is the drug of choice. right? So now we know how we are going to treat the hypokalemia and hyperkalemia. Hyperkalemia में acute में you are first of all you just try to stabilize the cardiac muscle, otherwise what is going to happen, I have explained you, this patient can end up into ST elevation, and this patient can end up into myocardial infarction, right? Patient can die, right? Second thing you need to do, you need to utilize this potassium, you need to utilize these drugs which are going to do the influx of potassium inside the cell, right? That is going to be your regular insulin. Along with that we can also use nebulization of salbutamol, right? And bicarbonate if needed, if the acidosis component is there, right? So based on this we are going to manage our patient, and in this particular case first thing that we want to do based on the ECG, based on the case, first thing we want to do is going to be your calcium gluconate, and that is going to stabilize your cardiac muscle. Did you get it? Right? No issues with this? Should we move forward? Give me a quick confirmation. Now we are going to discuss about this particular question. Try to answer this. So the question says a 24-year-old IV drug abuser. I hope all of you will get this. A 24-year-old IV drug abuser patient, IV drug abuser, okay, is presented to emergency with fever. Patient is having what? Fever since last 1 week. एक हफ्ते से fever है, right? On auscultation we heard a new murmur. The patient is having a murmur. The WBC count is 20,000 मतलब ल्यूकोसाइटोसिस हो रहा है. ऑन फंडोस्कोपी हम आंखों में देख रहे हैं. व्हाट वी आर फाइंडिंग abnormal spots are there, right? Which of the following is used for the diagnosis of this particular thing? What is your diagnosis? First of all, tell me your diagnosis. What do you think? What is this case? What is your diagnosis? What is your diagnosis? Yes, it is going to be your infective endocarditis. It is going to be your infective endocarditis. It is going to be your infective endocarditis, right? Now what we are going to do in infective endocarditis, we are going to see for the hallmark. So whenever we are having infective endocarditis, the patient will be having vegetations. Patient will be having vegetation on the heart wall. Vegetations will be there, and they will be present on the heart walls, right? That is going to be a hallmark feature of the endocarditis. Can anyone tell me what is the most common cause of acute endocarditis? Or you can tell me subacute. Subacute का cause क्या होता है? Subacute endocarditis, right? We are having acute endocarditis, subacute endocarditis. We are having like prosthetic valve endocarditis. Definitely question will be coming in your exam from endocarditis, right? Some organisms are there. I've taught you in microbiology. Some organisms, Hackett group of organisms, Coxella burnetii, that is going to cause culture negative endocarditis, right? So prosthetic valve, and we are having like IV drug abusers. So what are the organisms which are going to cause these carditis, right? Try to answer. Most common cause of acute carditis, most common cause of acute carditis is going to be your Staph aureus. Very good. That is going to be your Staph aureus. Subacute, साबे के अंदर क्या होता है? साबे, the most common cause is going to be your Streptococcus viridans. I've taught you viridans, right? Prosthetic valve endocarditis, that is going to be your coagulase negative streptococci, that is going to be Staph epidermidis, जो body के ऊपर present होता है, skin के ऊपर, right? And we are also having this particular thing can be due to viridans also. Prosthetic valve, right? IV drug abusers, that is definitely going to be your Staph aureus. So in this case we are having what? IV drug abuser patient, that is going to be your Staph aureus will be there, right? Now how do we understand, how do we extract what is this endocarditis, how this particular thing is going to be there? Let's try to understand what is the differential criteria we are having, right? The criteria that we are going to use is going to be your Duke's criteria or modified Duke's criteria, right? Where do we use this Duke score? ये सारी चीज़ें होती है, ऐसा नहीं है कि नहीं होती है. Duke score is the score we are going to use for a cardiac test, and cardiac treadmill test we are doing for ECG, right? That is going to be the Duke score. Duke's staging we have studied in surgery, right? That is going to be your colorectal carcinoma. That is the staging for colorectal carcinoma. Colorectal carcinoma, right? And this Duke's method, Duke's method is going to be utilized for the assessment of bleeding time. Assessment of bleeding time. Assessment of bleeding time. And this Duke's criteria we are going to use for infective endocarditis. इन्फेक्टिव एंडोकार्डाइटिस का मतलब क्या हुआ? एंडोकार्डाइटिस मतलब देखो हार्ट के अंदर की जो वॉल होती है उसको बोलते हैं एंडोकार्डियम. उसके अंदर क्या होता है? वेन एवर दे आर गोइंग टू टॉक टू यू अबाउट एंडोकार्डाइटिस यू हैव टू थिंक इन द टर्म्स ऑफ वॉल्व्स. ये वॉल्व्स की बात कर रहे हैं. ओके कोई सा भी वॉल्व हो उसकी बात कर रहे हैं. दैट इज गोइंग टू बी एंडोकार्डाइटिस, राइट? सो व्हाट इज गोइंग टू हैपन? व्हाट इज द क्राइटेरिया? दैट इज गोइंग टू बी योर modified Duke's criteria. Let's try to understand what are the things we are having. So we are going to have major criteria and minor criteria. मेजर क्राइटेरिया में क्या याद रखना है? देयर शुड बी 2 ब्लड कल्चर. ओके ब्लड कल्चर करते हैं. वी आर गोइंग टू टेक द ब्लड सैंपल एंड देन वी आर गोइंग टू डू द कल्चर, राइट? सो ब्लड कल्चर पॉजिटिव आना चाहिए 2 बार 12 आवर्स अपार्ट में. दैट इज गोइंग टू बी द फर्स्ट मेजर क्राइटेरिया. सेकेंड थिंग, इको कार्डियोग्राफिक एविडेंस ऑफ एंडोकार्डियल इन्वॉल्वमेंट. दैट मीन्स वहाँ पर क्या होनी चाहिए बेटा? वेजिटेशंस होनी चाहिए, right? So there will be some vegetations, that is going to be the major criteria, right? In minor criteria we are going to have what? Timer is the mnemonic. That is going to be temperature. That is going to be more than 38 degree. Immunological phenomena like Osler nodes, Roth spots will be there. Okay, microbiological evidence should be there, right? We are having embolic phenomena. Okay, एंड लास्टली वी आर हैविंग सर्टेन रिस्क फैक्टर्स. ओके रिस्क फैक्टर्स होने चाहिए. आईवी ड्रग अब्यूजर्स हो गया या कंजेनाइटल हार्ट कंडीशंस हो गई, प्रोस्टेटिक वॉल्व वाला पेशेंट हो गया, राइट? सो दैट इज कोई सर्जरी करवाया हुआ पेशेंट हो गया. सो ऑल दिस आर गोइंग टू बी इन द माइनर क्राइटेरिया. फॉर द डायग्नोसिस वी नीड व्हाट? वी नीड 2 major criteria and we need either we need 2 major criteria, either we need 1 major or 3 minor, 1 major or 3 minor criteria, right? Or we need 5 minor criteria. That is going to be the diagnosis. That is how we are going to be the definitive diagnosis. Possible diagnosis में क्या करना है? 1 major or 1 minor will be there or 3 minor criteria will be there. 3 minor criteria, 1 major plus 1 minor, right? That is how we are going to make the diagnosis. Apart from that we are also having different things. What are these things? इनके image based question आ जाते हैं या फिर ये मतलब क्वेश्चन के साथ में ऐड ऑन कर देते हैं with the infective endocarditis case, right? So what do you need to remember? These are going to be your what? These are going to be your splinter hemorrhage. Splinter hemorrhage. Like in our question they have given you on fundoscopy you are finding something. So what is that something that we are finding? They are known as Roth spots. They are known as Roth spots. They are known as Roth spots, right? And what are these nodes? These nodes are known as Osler nodes. Osler nodes, very very important, right? And we are having these non-palpable tender lesions. These are known as Janeway lesion. Janeway lesions. These are known as Janeway lesions. So these are going to be the things that you have to remember. And ultimately how we are going to do the treatment, right? How we are going to do the treatment of this particular thing. Before that, let's try to understand this. These are your vegetations on the walls, right? So we can have endocarditis with the rheumatic heart disease, right? What is going to happen? You will be having these vegetations along the lines of closure. These are the things they are asking from the pathology also, so you just need to go through this once, right? Next thing, in infective endocarditis you will be having this large bulky irregular vegetations, right? Non-bacterial thrombotic endocarditis, that is going to be your small and friable vegetations will be there. And remember, this NBT is going to be associated with the cancers, and this is also known as merintic type of endocarditis. Merintic type of endocarditis. Merintic type of endocarditis. And this Libman-Sack endocarditis, your previous year question, they have given you like a patient who is associated with the SLE, and SLE, this patient is going to have special type of endocarditis. That is going to be your Libman-Sack endocarditis. Libman-Sack endocarditis. Okay, both the surfaces are involved, right? These are the keywords. How you are going to treat this particular patient? So first of all, when the patient is going to come to us, we do not know what this patient is going to have. So first treatment that we are going to give, that is known as empirical treatment. First of all, we are going to give empirical treatment to the patient. Okay, what are the drugs we are going to use? We are going to use vancomycin here plus ceftriaxone. Vancomycin plus ceftriaxone. Sometimes we can also use gentamicin, right? Then we are going to go for the culture, and after the culture either we can change our drug, right? If for example this particular patient is having staph aureus, which is worse, right? Vancomycin resistant staph aureus, then we need to change our drug to daptomycin or linezolide, right? So that is what is going to happen after the culture. We are going to go for the definitive treatment, right? Definitive treatment. So this is how we are going to manage our patient for infective endocarditis. Very, very important. This criteria that has been multiple times asked. This is your Duke's criteria, modified Duke's criteria that we are having here, right? Next question we are having in front of us. A 42-year-old male patient is presented to emergency with the hypotension. Patient is having what, beta? Patient is having hypotension. Patient is having chest pain, pain in the chest. Restlessness is over there. Patient is having restlessness. On JVP examination, JVP, very important question of this patient, what we are finding? We are finding Y descent, and Y descent is absent. Basically, Y descent is absent, and X wave is prominent. X wave is prominent, right? These findings are suggestive of what? These findings are suggestive of what? Try to answer. These findings are going to be suggestive of what? So what is JVP? Jugular venous pressure. What is JVP? Jugular venous pressure, right? This pressure is going to be measured where do we measure this particular pressure? Okay, remember, this pressure is going to be measured in the right internal jugular vein. It is going to be measured in the right internal jugular vein, right? What is going to be the normal JVP pressure? What is your normal JVP pressure, beta? What is going to be normal JVP pressure? So the normal JVP pressure is 5 to 8 centimeter of H2O. It is going to be 5 to 8 centimeter of H2O. Very good, guys, you are answering right. If it is more than 8, then we call it raised JVP. Then we call it raised JVP. Okay, raised JVP. Right, now let's try to understand what is this JVP is formed, how this JVP is formed, and what are the interpretation of this particular thing. Okay, so basics are what? Basics are, for example, this is your heart again, right? You are having this right atrium, this right ventricle, left atrium, and left ventricle, right? So what is going to happen? This JVP is going to tell us about the situation or the things about the right atrium. It is going to tell us about the things which are happening in the right atrium. So that is going to be the JVP. Right? So we are going to have certain waves. We are going to have A wave, we are going to have C wave, we are going to have V wave, and two descents we are going to have, that is going to be X descent and Y descent. Let's try to understand what is this happening, right? So we are going to have here vena cava, and this is what is going to transmit the pressure to the IGV, right? So what is going to happen? Look here. So we are going to have this right atrium. So A wave is telling us about the depolarization. You can simply remember A is going to tell us about the atrial सिस्टोल या depolarization, दोनों का मतलब एक ही होता है, that is going to be contraction. So whenever atrias are contracting, what is going to happen? There will be more pressure, and that is going to lead to formation of A wave. This X descent, not so important, right? Then we are having C wave. Why this C wave is coming? Because now what is happening? Tricuspid valves are closed. Tricuspid valves are the valves which are going to be present over here, right? If these valves are closed, and ventricle is trying to contract, now what is going to happen? So if there is tricuspid valve which is closed and ventricles are contracting, what will happen? There will be a bulging of tricuspid valve, into the right atrium, leading to increase in the pressure in the right atrium. That is what we are seeing as the C wave. And this is your previous year question. The C wave is going to indicate what? So C wave is tricuspid valve closes and right ventricle trying to contract. So it is due to isovolumic contraction. What is happening? The tricuspid valve bulging into the atria. Suppose these are your atrias. So now what is happening? This tricuspid valve is bulging because it is trying to contract, right? Next we are having x से याद रखो, what you need to remember, x is going to be relax, right? X is going to relax, right? So we are having end of right ventricle contraction. It will create extra space within pericardium, allowing the right atrium to beginning the filling with the blood, right? Basically what is happening, so whenever we are having this particular thing, now it is relaxed. Now when it is relaxed, what is going to happen? There will be some relaxation, there will be some extra room, leading to what? Leading to relaxation, and that is what is going to give you x descent. Now we are having v. What you need to remember, v is going to be your v for vena cava, filling will be there. V से क्या याद रखना है? फिलिंग याद रखना है. So what is going to happen? Filling of right atrium against a closed tricuspid valve. So now this valve is closed और यहाँ पर क्या हो रहा है? यहाँ पर blood इकट्ठा हो रहा है. उसकी वजह से क्या होगा? Again the pressure will rise. That is going to give you V wave, right? And now what is going to happen? Y descent is why? Y descent is due to tricuspid valve will open and the whole blood from the above chamber will be going to the below chamber. That is known as emptying. So what you need to remember, look here, I am going to make you understand the simple things. Look here. So A is telling us about the atrial systole. C is going to tell us about the isovolumic contraction, and here you will be having bulging of tricuspid valve into the right atrium. Okay, so tricuspid valve is going to bulge into right atrium. That is going to be C wave. Okay, V is going to tell first x is going to tell us about the relaxation. So now what is happening? Now there is no blood in the right ventricle is also relaxing. So what is going to happen? There will be extra room will lead to relaxation, right? After x we will be having v. What you need to remember from v is going to be telling us about the vena cava filling. So you will be having vena cava filling. So here definitely V is going to show you positive changes because अभी blood अंदर आ रहा है, right? And lastly we are having Y से याद रख लो emptying, right? So Y for Y you can remember emptying. Y is going to tell us about the emptying. A for atrial systole, C for contraction, X for relaxation, V for vena cava filling, and Y for emptying. If you remember this, that is going to be good enough, right? So now what is going to happen when we are going to have these pathological JVP waveforms, right? So absent A wave, if you understand what I've told you, you will be able to understand. Absent A wave कब absent होगी? Atrial fibrillation में क्या हो रहा है? Atrias are fibrillating too fast, very fast they are fibrillating, they are not able to contract properly. अगर properly contract नहीं होंगे तो क्या atrial systole होगा? नहीं होगा. So absent A wave will be seen in the atrial systole, right? Large A waves are seen in the pulmonary hypertension, pulmonary stenosis. Pulmonary stenosis मतलब यहाँ पर कुछ ना कुछ प्रॉब्लम हुआ है. Pulmonary hypertension यहाँ प्रॉब्लम होगा तो यहाँ पर fluid accumulate होगा, and if the fluid is accumulating here, what will happen? Ultimately the fluid will accumulate here, leading to increase in the pressure, leading to large A wave formation. Canon A wave कब होगी? Whenever there is problem with the transmission. ऊपर से नीचे कुछ नहीं आ रहा, ऊपर से नीचे कंप्लीट हार्ट ब्लॉक, राइट? कंप्लीट हार्ट ब्लॉक, व्हाट इज गोइंग टू हैपन? The atrias are not contracting with the ventricles, right? यहाँ से current generate तो हो रहा है, but this current is not going to go below. Ventricles are on their own, right? Now atria are different, ventricles are different. तो यहाँ पर क्या होगा? Canon A waves, very large A waves, because here you will be having lots of pressure, right? Ventricle arrhythmias can lead to same thing, right? Large V wave कब मिलेगी? When we are going to have large V wave, whenever we are going to have tricuspid regurgitation. Large V wave is telling us about the vena cava filling. तो ऊपर से फिलिंग हो रही है, बट हियर वी आर हैविंग रीगर्गिटेशन. रीगर्गिटेशन मतलब यहाँ से ब्लड वापस आ रहा है, उल्टी करना, वापस जाना, राइट. सो वी आर हैविंग ट्राइकस्पिड रीगर्गिटेशन. दैट मीन्स द ब्लड फ्रॉम द वेंट्रिकल्स आर ऑल्सो गोइंग इन टू द एट्रिया. यहाँ से भी ब्लड आ रहा है. यू विल बी हैविंग large V wave. Your previous year question, this is also known as giant CV wave, right? This is also known as giant CV wave, right? Next thing, rise in JVP during inspiration. This is known as Kussmaul sign, and this is going to be positive in the cases of constructive pericarditis. This is going to be positive in the cases of constructive pericarditis. Okay, one more thing you can remember from here: X descent. X descent. Okay, when you are going to have rapid X descent, rapid X descent is seen in the cases of constructive pericarditis, restrictive cardiomyopathy, and in the cases of cardiac tamponade. So these are the three things where you are going to have rapid X descent or prominent X descent, and there will be absent X. There will be accent X in the tricuspid regurgitation, right? So tricuspid regurgitation, two things you already know. First thing, there will be large V wave. Second thing, there will be absent X, absent X. These are the two important points for tricuspid regurgitation. Question has already been asked on this, right? Next thing about the Y descent, last thing that you need to remember here. Once you go through all this, definitely it will be easy for you once you need to go through this, but right. So rapid Y descent will be there. Here you will be having rapid Y descent, right? Where do you find rapid Y descent? In the cases of constructive pericarditis. So constructive pericarditis क्या समझे sir? Constructive pericarditis, three things we get to know. First thing, there will be Kussmaul sign. Second thing, there will be rapid X descent. Third thing, there will be rapid Y descent, right? Whereas this Y will be absent. Absent Y is seen in the cases of cardiac tamponade. कार्डियक टेम्पोनाड में X तो प्रोमिनेंट होगा, कार्डियक टेम्पोनाड में X तो प्रोमिनेंट होगा. दिस X is going to be prominent, but there will be Y absent. If you remember this point in previous year exam, we are having 3 questions in last exam. लगातार 3 एग्जाम में क्वेश्चन वी आर हैविंग. प्लीज गो थ्रू दिस, राइट? रैपिड एक्स यू विल बी हैविंग इन द कंस्ट्रक्टिव पेरिकार्डाइटिस, कार्डियक टेम्पोनाड, आरसीएम. कंस्ट्रक्टिव पेरिकार्डाइटिस यहाँ पर भी होगा, कुस्मूल साइन भी होगा. व्हाट अबाउट कार्डियक टेम्पोनाड? सर कार्डियक टेम्पोनाड विल बी एब्सेंट वाई, एब्सेंट वाई. इफ यू रिमेंबर दिस इन्फॉर्मेशन यू विल बी एबल टू आंसर दिस क्वेश्चन. दैट इज द क्वेश्चन दे हैव आस्क्ड यू, राइट? So the question says Y descent is absent. Where do you find Y descent is absent? So it cannot be constructive pericarditis because Y descent is going to be present there, and X wave is prominent where? X is prominent here also, X is prominent here also, but here Y is going to be absent, and this is the question they are asking again and again. The answer here will be D. Answer here will be D because this particular thing will be cardiac tamponade will be having absent Y. Absent Y will be there, right? What is this cardiac tamponade? Simple understanding देता हूँ, right? Here suppose this is your heart. Around your heart you will be having what? You will be having this pericardium, और इसके अंदर क्या हो गया बच्चों? इसके अंदर fluid भर गया. We are having accumulation of fluid over there, right? So this is going to be your cardiac tamponade. इसी को क्या बोल देते हैं हम लोग? Cardiac tamponade. And what is the special triad that you see always? Cardiac tamponade में कौन सा triad मिलते हैं? What is the triad we are having? That triad is known as backstride. Backstride. Triad को क्या बोलते हैं? Backstride, right? In the question also, if you don't remember these things, we are having the backstride. What is that backstride? Hypotension is there, rise on JVP is there, right? So what is that backstride? Let's try to understand. So backstride says there will be increase the JVP. JVP will be increased, right? So now you understand why this JVP will be increased, because there is too much pressure. Because there is too much pressure here, what is going to happen? This heart will contract. This heart will not able to pass this ventricles are not able to contract properly because we are having lots of fluid here, lots of pressure here. तो ventricles ढंग से contract नहीं करेंगे. What will happen? The pressure will accumulate in the atria. And atria में pressure बढ़ेगा तो क्या होगा? Internal jugular vein में pressure बढ़ेगा. That is what is going to show us the increase in the JVP, and that is going to be your non-pulsatile JVP. Non-pulsatile, very very important this term. Non-pulsatile rise in JVP. Why this is happening? Because pressure ज़्यादा है. Second thing, what is going to happen? अगर यहाँ pressure ज़्यादा पड़ा, चलो लेट्स ट्राई टू अंडरस्टैंड। यहाँ पर भी तो प्रेशर ज़्यादा पड़ेगा लेफ्ट वेंट्रिकल में, राइट, बिकॉज दिस ventricles is not able to pump clearly. If ventricles are also not pumping clearly, what is going to happen? This is going to present as hypotension. बॉडी में ब्लड अच्छे से नहीं पहुंचेगा, that is going to be the hypotension. Are you agree with this? This person is going to have hypotension, raise the GVP, hypotension. And when you are going to hear the sound from here, right, when you are going to put your stethoscope here, what you are going to find? You are going to find what kind of sounds? You are going to find muffled heart sound. Why these sounds are muffled? Sir, यहाँ पर बाहर पानी भर, right? So you will be having muffled heart sound. हार्ट साउंड, यू जस्ट नीड टू रिमेंबर द सिंपल फैक्ट। अगर कॉन्सेप्ट बन गया, कॉन्सेप्ट क्या है? देर विल बी वाटर अराउंड द हार्ट, वाटर विल बी देयर अराउंड द हार्ट, सो व्हाट इज गोइंग टू हैपन? फ्लूइड विल बी देयर, तो उसकी वजह से क्या होगा? कॉन्ट्रैक्ट नहीं कर पाएगा हार्ट। इफ हार्ट इज नॉट एबल टू कॉन्ट्रैक्ट प्रॉपरली, यू विल बी हैविंग इंक्रीज इन द जेवीपी, यू विल बी हैविंग एक्यूमुलेशन ऑफ फ्लूइड इन द हार्ट इटसेल्फ। बॉडी में फ्लूइड अच्छे से नहीं जाएगा, लेफ्ट वेंट्रिकल अच्छे से कॉन्ट्रैक्ट नहीं करेगा, एंड देन you will be having what? Hypotension. So this is the triad that we are having, raised JVP, hypotension and muffled heart sound, right? What kind of ECG you will be getting? पानी भरा है इसके साथ में, you will be definitely getting low voltage ECG, low voltage ECG. Okay, on X-ray you will, on radiograph you will be getting a special appearance that is known as water bottle appearance, that is known as water bottle appearance, और मनी बैग भी बोलते हैं. दिस अपीयरेंस इज ऑल्सो नोन एज मनी बैग अपीयरेंस. हाउ यू आर गोइंग टू ट्रीट दिस पर्टिकुलर सिचुएशन? हाउ यू आर गोइंग टू ट्रीट दैट पर्टिकुलर सिचुएशन? For the treatment you are going to do what? Pericardiocentesis. Pericardiocentesis. यहाँ से जो पानी भरा हुआ है इसको निकाल दोगे, थोड़ा सा भी पानी निकालोगे here, what will happen? There will be a great relief you will be finding, right? So that is going to be the pericardiocentesis, right? What happens in the constructive pericarditis? इसको भी देख लो थोड़ा सा. Constructive pericarditis most common seen in the TB, right? TB में कौन सा होता है? TB pericarditis और bread and butter pericarditis, right? And what is the treatment you are going to give here in constructive pericarditis? There will be pericardial resection you are going to do. So in cases of pericarditis you will be doing pericardial resection. Pericarditis में क्या हुआ? There will be some hardening, there will be some fibrosis. यहाँ पर क्या हुआ? यहाँ पर पानी भर गया सर, यहाँ पर fibrosis हुआ है. We need to do the pericardial resection. I hope these two terms are clear to you. Okay, let me fix the camera. Just give me a minute. There is some problem with the camera. Can we continue like this? I don't know, because it's not working. Let me know if you can go study like this without looking at me. Because the exam is near. Let me give the final try. It's working. No shoes. We are having exam tomorrow. Also, we are having class. I'll fix it up till tomorrow. Right? Just give me a moment. Are you able to hear me? All right. So the next question we are having in front of us is about the cardiomyopathy, right? So there is a footballer who had a history of sudden cardiac death. He has collapsed suddenly during the game, right? He was brought to the hospital, but the doctors could not save him. Family said that the other sibling had the similar kind of death, right? उसका भाई भी ऐसे ही मरा था. While running, what could be the possible diagnosis over here? So what is your diagnosis? First of all, it is a case of cardiomyopathy. कार्डियोमायोपैथी मतलब कुछ ना कुछ कार्डियक मसल के अंदर प्रॉब्लम है, राइट? देयर इज प्रॉब्लम विद द कार्डियक मसल. हमने अरिथमिया पढ़ा, अरिथमिया वाज समथिंग प्रॉब्लम विद द रिदम, राइट? इट्स नॉट अबाउट द रेट, इट्स अबाउट द रिदम. हियर वी आर हैविंग द प्रॉब्लम विद द muscles, the problem with the muscles. So what are the different kind of cardiomyopathy we are going to have? Let's try to understand, right? So first of all we are having HOCM. HOCM मतलब hypertrophic obstructive cardiomyopathy. Here we will be having mutation of, here we will be mutation of beta myosin gene. देखो important topic है cardiomyopathy. Here we will be having mutation of beta myosin gene which is going to be present on chromosome number 14. जहां भी हो try to speak. It is going to be present on chromosome number 14. Okay, कैसा क्वेश्चन देते हैं? The question they will be giving you like young male will be there. एक young लड़का है वो खेल रहा है, या कोई जिम गया है, या फिर फुटबॉलर है. सो दे विल बी गिविंग यू हिस्ट्री. young male with sudden cardiac death, sudden cardiac death. You have to think in the terms of HOCM. You have to think in the terms of HOCM. देखो HOCM में इको के अंदर क्या मिलेगा? Okay, there will be banana shaped cavity. Banana shaped cavity will be there, right? और ट्रीटमेंट ऑफ चॉइस क्या है इसका? हाउ यू आर गोइंग टू ट्रीट? वो जो कैविटी है उसको अब्लेट कर दो. ट्रीटमेंट विल बी अल्कोहल अब्लेशन. अल्कोहल अब्लेशन ऑफ द सेप्टम, वॉट एवर इज ग्रोन, उसको काट दो, उसको अल्कोहल से अब्लेट कर दो. एंड द ड्रग ऑफ चॉइस विल बी propanolol. So this is pretty much that you need to remember about the HOCM. Look here, this is going to be your hypertrophic obstructed cardiomyopathy. यहाँ पर क्या हुआ? ये जो सेप्टल है ये बड़ा हो गया, ये सेप्टा बड़ा हो गया, तो क्या यहाँ से ब्लड बाहर जा पाएगा? नहीं सर, ब्लड बाहर जाने में प्रॉब्लम होगी. एंड दैट इज व्हाट इज गोइंग टू कॉज द हाइपरट्रोपिक ऑब्स्ट्रक्टिव कार्डियोमायोपैथी. दिस इज योर HOCM, राइट? सडन कार्डियक डेथ वाला क्वेश्चन होगा. नेक्स्ट थिंग दैट वी आर हैविंग इज गोइंग टू बी योर dilated cardiomyopathy. Dilated cardiomyopathy. डायलेटेड में क्या होगा? देर विल बी डायलेशन, राइट? मोस्ट कॉमन कॉज क्या होता है? देर विल बी डायलेशन ऑफ द हार्ट. मोस्ट कॉमन कॉज क्या होता है यहाँ पर? मोस्ट कॉमन कॉज इज एल्कोहल. मोस्ट कॉमन कॉज पे क्वेश्चन है, दैट इज गोइंग टू बी योर एल्कोहल. दोज पीपल हु आर टेकिंग व्हाट? एल्कोहल, राइट? हियर यू कैन हैव mitral regurgitation, you can have tricuspid regurgitation, and you can have pain, systolic murmurs, right? So everything will be there. Investigation of choice, how you are going to identify? Okay, how you are going to identify? This is going to be echocardiography. This is going to be your echocardiography that you are going to do. Echocardiography, right? And treatment कैसे करोगे? Treatment is nothing, you just need to do what? Heart transplant. What you need to do? That is going to be your heart transplant करना पड़ेगा. There is nothing else that you can do about it, right? Next we are having is going to be your last, that is going to be your restrictive type of cardiomyopathy. यहाँ पर सब में क्या है? एक में हार्ट की वॉल्स डायलेट हो गई, एक में क्या हुआ? देयर इज सेप्टा, वो मोटा हो गया. दैट इज गोइंग टू बी HOCM. दैट इज गोइंग टू बी योर डायलेटेड कार्डियोमायोपैथी. रेस्ट्रिक्टिव के लिए व्हाट इज द मोस्ट कॉमन कॉज? हियर यू विल बी हैविंग डिपोजिशन ऑफ एबनॉर्मल प्रोटीन्स. Here you will be having deposition of abnormal proteins. And what are those abnormal proteins we are having? These are known as amyloid, right? So amyloidosis हो जाता है यहाँ पर. ECG will be showing you what? ECG will be low voltage. Remember here also the ECG will be low voltage. क्योंकि क्या हुआ? अमाइलोइड डिपॉजिट हो गया, तो क्या करंट मशीन असेस कर पाएगी? गैल्वेनोमीटर नहीं कर पाएगा सर अच्छे से. यू विल बी हैविंग लो वोल्टेज ECG, राइट? इन्वेस्टिगेशन ऑफ चॉइस विल बी cardiac MRI. You need to do what? Cardiac MRI will be the investigation of choice. And lastly we are having when we are going to do the echocardiography in this particular case, ये भी एक बार पूछा गया है, that is going to be, you will be finding square root sign. You will be finding what? Square root sign. And for the treatment beta, treatment is going to be again कुछ नहीं कर सकते, you need to do heart transplant. हार्ट ट्रांसप्लांट. अमाइलोइड का तो वैसे ही कोई ट्रीटमेंट नहीं है, बट व्हाट यू कैन डू इज यू कैन गिव सिम्टोमेटिक ट्रीटमेंट एज वेल. थोड़ा बहुत सिम्टोमेटिक ट्रीटमेंट दे सकते हो, बट ultimate treatment is the heart transplant, right? So these three things we are having: HOCM, dilated and restrictive type of cardiomyopathy. So in this particular case they are asking the classical case, and in this classical case they want to know about a person who was playing and he had a sudden cardiac death. sudden cardiac death while running, while jogging, or while like gymming. So ये सारी चीज़ें क्या है, hypertrophic cardiomyopathy, right? अपार्ट फ्रॉम दैट व्हाट विल हैपन इन द हार्ट अटैक? हार्ट अटैक को तो दूसरा नाम क्या है, मायोकार्डियल इन्फार्क्शन। मायोकार्डियल इन्फार्क्शन यानी ये जो एथरोस्क्लेरोसिस बना है, यहाँ से ऑक्सीजन जो हार्ट है वहाँ तक पहुँच नहीं पा रही है, दैट इज वाई दिस हार्ट टिश्यू इज गोइंग टू गेट डैमेज एंड दिस इज नॉन एज hypertrophic obstructive cardiomyopathy, right? So this is sorry, this is known as heart attack. This is known as heart attack, right? Okay, so now the next thing we are having is pulses at tardus are seen in. Pulses at tardus is seen in. Try to answer this one. Pulses at tardus कहाँ देखने को मिलती है? So where do you find this pulses at tardus? Pulses at tardus is seen in. Try to answer. Pulses at tardus. Very good. That is going to be in the aortic stenosis. So pulses का मतलब क्या होता है? पहली चीज तो what is pulses? Okay, so basically they are the pressure waveforms. They are the pressure waveforms जो क्या बताती है, लेफ्ट वेंट्रिकुलर का कॉन्ट्रेक्शन. दे आर गोइंग टू टेल अस अबाउट द कंडीशन ऑफ द लेफ्ट वेंट्रिकल. तो हम जो हाथ की पल्स पकड़ते हैं, व्हाट इट इज गोइंग टू शो, इट इज गोइंग टू टेल अस अबाउट द लेफ्ट वेंट्रिकुलर कॉन्ट्रेक्शन. लेफ्ट वेंट्रिकल का कैसा कॉन्ट्रेक्शन है, राइट? एंड इट इज बेस्ट फेल्ट वेयर, बेस्ट फेल्ट इन कैरोटिड आर्टरी. सबसे बेस्ट कहाँ फेल्ट कर सकते हो? कैरोटिड आर्टरी के अंदर. बेस्ट फेल्ट एट कैरोटिड आर्टरी. बट द मोस्ट इंपॉर्टेंट थिंग, व्हाट आर द टू पल्सेस विच आर एक्सेप्शन वी कैन नॉट फील एट द कैरोटिड आर्टरी? दिस वन इज योर पल्सस बिस्फेरेंस एंड पल्सस अल्टरनेंस. ओके, ये दोनों कहाँ फील करोगे? दीज टू यू विल बी फाइंडिंग एट द रेडियल आर्टरी. ये रेडियल में ज़्यादा बेटर होती है, राइट? सो दैट इज गोइंग टू बी योर बिस्फेरेंस एंड दैट इज गोइंग टू बी योर अल्टरनेंस, राइट? Now let's try to understand what are the different pulses we are having. Let me make a short note so that you can watch just before your examination. So we are having anacrotic pulse, also known as pulses at tardus. Pulses at tardus. ऐसा क्यों बोला? Because this is a pulse which is having a slow rise and a low amplitude. This pulse is a slow rising pulse, धीरे धीरे बढ़ेगी, एंड विद लो एम्पलीट्यूड. इसका एम्पलीट्यूड भी कम होता है. स्लो राइजिंग पल्स विद लो एम्पलीट्यूड. दिस इज सीन इन द केसेस ऑफ aortic stenosis. This is seen in the cases of aortic stenosis. And why we are having this particular thing? Because of carotid thrill. Carotid thrill की वजह से पता चलता है. That is going to be your anacrotic pulse or pulses at tardus, right? What is this pulsus bisferens? Pulsus bisferens ये कहाँ मिलेगी? Pulsus bisferens is seen where? Here you will be having a fast rise and fast fall. Fast rise and fast fall will be there with two peaks in systole. This is what we are finding in the cases of HOCM, because it is why it is happening? Because of systolic problems. Right? Next we are having is Corrigan or dancing pulse, or Corrigan or collapsing. Corrigan or collapsing or water hammer pulse. This is what we are finding in the cases of aortic regurgitation. I'm just making a note so that you can revise here. Aortic regurgitation. I have explained all these things in the physiology section, right? So You can watch that, right? Next one we are having is the dicrotic pulse. Dicrotic pulse. This is what we are seeing in the cases of dilated cardiomyopathy, right? Pulsus alterans. Pulsus alterans. Alterans कहाँ मिलता है? That is going to be in the left ventricular failure. Left ventricular failure. Left ventricular failure, right? Next we are having is pulsus paradoxus. Pulsus paradoxus. Pulsus paradoxus we can see in the cases of hypotension. Normally देखो hypotension में normally there should be less than 10 mm of Hg fall in BP during inspiration. Normally inspiration में 10 mm से कम fall होना चाहिए, but here pulsus paradoxus में more than 10 mm of Hg fall is seen. Hg fall in BP during inspiration. तो इसीलिए इसको क्या बोलते हैं? इसीलिए इसको पैराडॉक्सिस बोलते हैं. नॉर्मली 10 से कम होना चाहिए, यहाँ 10 से ज़्यादा होता है, राइट? सो दैट इज नोन एज पल्सस पैराडॉक्सिस विच इज सीन इन द केसेस ऑफ हाइपोटेंशन. एंड यू ऑलरेडी नो इर्रेगुलर पल्स कहाँ देखी थी? इर्रेगुलर पल्स इज सीन वेयर we have seen that in the cases of atrial fibrillation. Atrial fibrillation. So that is what we need to remember, right? So these are the pulse that you have to go through just before your examination. नाम याद कर लो, कहाँ से है वो याद कर लो. Anacrotic, pulsus at tardus, aortic stenosis, pulsus bisferens, HOCM. Okay. Next is your Corrigan, that is going to be aortic regurgitation. Dicrotic, D4D, that is going to be dilated. Okay. Pulsus alterans, that is going to be your left ventricular failure. Paradoxus in the hypotension, and irregular pulse will be seen in the cases of atrial fibrillation, right? Now next question for you. A 47-year-old male patient is presented to emergency with the symptoms of, patient को क्या हो रहा है बेटा? Patient को हो रहा है retrosternal radiating chest pain. Patient is having pain on the chest, right? And diaphoresis हो रहा है, and he was a smoker patient, and he has a positive family history of cardiac events, right? The ECG was done and shown below. What is the likely diagnosis? Is it your anterior, posterior, inferior, lateral? Which wall am I? Try to look at the ECG and try to find out which wall am I is this. Which wall am I is this? Which wall am I is this? You want more zoom? Look here. So where do you see the ST elevation? Try to understand how to find out these things. Okay, so सबसे पहले क्या देखना है? The most important lead that you need to see is the lead number 2. Lead number 2 देखना है, right? So what is happening in the lead number 2? This is your lead number 2, right? Can you appreciate? This is your P के बाद में QRS के बाद में, can you appreciate this ST elevation? Can you appreciate this ST elevation here, right? This ST elevation is in the lead number 2. Yes, it is present in the lead number 2. It is present in the lead number 3 also, sir, right? It is not in the AVF, not in the AVR, not in the AVL, but it is present in the AVF, right? It is present in the AVF. These are the leads. We are having the ST elevation. So you can appreciate here, look here. So we are having ST elevation here, and in the AVF also, right? So this is what we are having: lead number 2, lead number 3, lead number AVF, right? So now we are going to understand how we are going to assess this with the help of the things, right? So first one, we are having the MI, myocardial infarction. You will be having what? You will be having hyperacute T waves will be there. Here you can find the ST elevation. ST elevation as non-STMI भी हो सकता है, and T wave inversion is going to be there. T wave क्या हो जाएगी? उल्टी हो जाएगी, right? What is the most common cause? If they ask you, the most common cause for MI is going to be your atherosclerotic plaque. एथेरोस्क्लेरोटिक प्लैग विल बी देयर, उसकी वजह से ऑक्सीजनेशन नहीं हो पाएगा हार्ट के पास में, एंड देयर विल बी फॉर्मेशन ऑफ दिस मायोकार्डियल इन्फार्क्शन, राइट. ऑन ईसीजी व्हाट यू आर गोइंग टू फाइंड ऑन ईसीजी, लुक हियर, देखो अगर V1 टू V4 और लीड नंबर 1 लीड नंबर AVL इसके अंदर कोई चेंजेस नज़र आ रहे हैं, दैट इज गोइंग टू बी योर एंटीरियर और एंटीरियो सेप्टल और एंटीरियो लेटरल वॉल MI, एंटीरियो लेटरल वॉल MI. Okay, and which is the artery that is going to be involved over here? This is going to be left anterior descending artery. This is going to be left anterior descending artery. Okay, second thing, अगर changes 2 3 और AVF में नज़र आ रहे हैं, if the changes are in 2 3 and AVF, this is going to be inferior wall MI. Very good, Sheikh. This is going to be inferior wall MI, right? So here we are going to have problem with the right coronary artery, right coronary artery, inferior wall MI. What is the artery supplying? That is going to be right coronary artery, right? V7 to V9 अगर दे रखा है और रेसिप्रोकल चेंजेस दे रखे हैं V1 V2 में, तो दैट इज गोइंग टू बी 7 8 9 जनरली वी आर नॉट यूजिंग, बट इफ वी आर यूजिंग दैट इज गोइंग टू बी योर पोस्टीरियर वॉल MI, posterior wall MI, right? And the artery that is going to be posterior descending artery, right? And lastly, if we are having changes in the V5 V6 lead number 1 and AVL, that is going to be a lateral wall MI, lateral wall MI. And here we are going to have involvement of lateral circumflex artery, lateral circumflex artery. Okay, left circumflex artery will be there, and that is going to be the lateral wall MI, right? So you can look here. So if the changes you are finding laterally, if the changes are in the V5 V6 and lead number 1, that is, and AVL, that is going to be in the favor of lateral wall MI, right? If changes in the 2 3 and AVF, that is going to be in the favor of inferior wall MI. This is your inferior, this is for the inferior wall MI, right? If the changes you are finding in the V1 to V4 first and AVL, that is going to be your anterolateral MI, that is going to be your anterolateral MI. This is how you are going to assess it, and these are the arteries. Just watch through it and you are able to understand and you are able to identify, right? So here in this particular case 2 3 and AVF is involved, so it is going to be which kind of MI? 2 3 AVF. Yes, very good. That is going to be inferior wall MI. This is how we are localizing the myocardial infarction. This is how we are localizing it, right? What about the treatment part? For the treatment of myocardial infarction, treatment, like you always study Mona, Sonam. So those things we will be doing first, right? Strepto kinase we are not using nowadays. So first thing we are going to use is going to be your morphine, oxygen, nitrates, antiplatelets, Mona, that is going to be antiplatelet. What antiplatelet therapy we are doing? Antiplatelet therapy that we are doing is your dual antiplatelet therapy, right? दो antiplatelet देने, right? Next thing we are going to do, if it is a non-ST elevation MI, if it is a non-ST elevation MI, we are going to do what? We are going to give beta blocker, that is going to be your metoprolol, right? Then we can give what? Anticoagulant, that is going to be your enoxaparin, and we can give antiplatelet, that is going to be your tirofiban. Okay, remember in non-STMI we are not going to do what? Contraindicated at what? Fibrinolytics. We are not going to do fibrinolysis, right? That is the NSTMI, right? For ST elevation MI, we are going to do what? Treatment of choice is going to be your percutaneous intervention. Percutaneous intervention, we are going to do, what is the door to balloon time? Door to balloon time, it should be done between how much time? Door to balloon time. Remember, the door to balloon time here will be less than 90 minutes. Agar within 90 minutes we are able to do this, we can go for percutaneous intervention if cath lab is available. कैथ लैब अवेलेबल है, पेशेंट आ गया तो पीसीआई कर दो, राइट? एक आर्टरी इन्वॉल्व है, दो भी इन्वॉल्व है तो कर दो पीसीआई, राइट? बट अगर पीसीआई अवेलेबल नहीं है, इफ नो पीसीआई इज अवेलेबल, परक्यूटेनियस इंटरवेंशन अवेलेबल नहीं है, देन वी आर गोइंग टू गो फॉर फिब्रिनोलाइसिस. गांव में हो, कहीं सीएचसी पे हो, पीएचसी पे हो, यू आर गोइंग टू गो फॉर fibrinolysis. Fibrinolysis के लिए door to needle time will be there. Door to needle time should be less than, door to needle time, it should be less than 30 minutes, yani within 30 minutes. If you know patient is coming to you, right now, what you need to do, you need to do fibrinolysis. PCI तो है नहीं, तो fibrinolysis कर दोगे. कैसे करोगे? What are the drugs you are going to use? Earlier we used to use streptokinase, but streptokinase can precipitate reactions. I've taught you in physiology that can that is a bacterial product coming from type C bacteria that is going to be equisimilus. तो वहाँ पर एंटीजन एंटीबॉडी रिएक्शन हो सकता है. सो वी आर गोइंग टू यूज रिकॉम्बिनेंट ड्रग्स, दैट इज गोइंग टू बी योर एल्टिप्लेस और रेटिप्लेस, अल्टिप्लेस और रेटिप्लेस. ओके, एंड व्हेन वी आर गोइंग टू डू CABG, बाईपास कब करोगे, CABG कब करोगे, and what is the artery you are going to use? This is your previous year question, internal memory artery, 2020 previous year question. That is going to be your internal memory artery is the artery that we are going to use, right? And if more than like 3 vessels are involved, more than 3 vessels are involved, then you are not going to go for PCI, you are going to do what? You are going to do CABG. फिर क्या करोगे? CABG कर दोगे, क्योंकि ज़्यादा vessels involved है तो bypass कर दो, right? So this is what we are going to do. Now next question we are having. A 12-year-old male child is presented to emergency, okay, with the symptoms of, what are the symptoms this particular patient is having? Joint pain है, right? Chest pain है patient को, nodules हो गए हैं, right, over the extensor surface after a sore throat infection. Very very important. What is the most common organism causing the disease, right? What is your diagnosis? What we are talking about here? Very important topic. That is going to be your rheumatic heart disease, RHD, which is precipitating what? कौन से infection के बाद में होता है RHD? Staph या Pyogenes या Pneumococcus? Try to answer, right? Remember, RHD is going to be a type 2 hypersensitivity reaction, type 2 hypersensitivity reaction, right? And here you will be having molecular mimicry, here you will be having molecular mimicry, and you can also call it cross reactivity seen, cross reactivity is seen, right? The bacteria which is going to be responsible here, very good, Saloni kusum, that is going to be your Pyogenes. Pyogenes is also known as group A beta hemolytic streptococci. This is a group A beta hemolytic streptococci. I have told you how, right? So what is the thing you are going to see here? This is a case of RHD, and the criteria we are using is Jones criteria, right? So what we need to do, we need to check for the major criteria. What are the major criteria? We are having joint involvement. O is looking like a myo, so you can remember O for O, myocarditis will be there. It is most commonly found, right? You can have nodules, you can have subcutaneous nodules, right? Erythema marginatum will be there. And sydenham chorea is a later manifestation. You will find it on the late side, right? So you can also have this chorea, right? So these are going to be your, Jones is going to be your major criteria. Apart from that, in minor criteria, you can have CAFE-PAL, right? That is going to be CPR will be increased, arthralgia, that means pain will be there, fever can be there, and ESR will be increased, erythrocyte sedimentation rate. There will be increase in the PR interval, okay, and anamnesis of rheumatism can be there, and leukocytosis, increased WBC count will be there. How you will make the diagnosis? Throat culture लेना है, right? Throat culture के अंदर what you are going to see? You are going to see anti-streptolysin O antibodies. अगर ये present है, ये तो essential criteria हो गया, right? ये present होना ही चाहिए, right? तभी जाकर हम क्या करेंगे, फिर क्या लेंगे उसके साथ में? 2 मेजर क्राइटेरिया अगर हो रहे हैं, या फिर 1 मेजर, 1 मेजर and 2 minor criteria, that is going to be the thing we are having for the rheumatoid heart disease, right? What is the most common age group that is going to be affected? Age group कौन सा affect होता है? The children of 5 to 15 years are more commonly affected, right? Most common valve involvement is going to be valvular disease. क्या होता है? Mitral regurgitation will be there, mitral regurgitation will be there. और पैथो से क्वेश्चन आता है, कौन सी बॉडीज मिलती है? mitral regurgitation होगा, और walls के ऊपर you will be finding what are the things you will be having. Ashkoff bodies, very very important. Ashkoff bodies, caterpillar cells, right? Caterpillar cells, Ashkoff body, right? And you can also have eosinophilia. So these are the important findings that you will be having, right, in the rheumatoid heart disease. And for the treatment, you need to give what? The drug of choice for this particular thing is going to be nothing but your benzathine penicillin G. Benzathine penicillin G, right? So this is what you are going to give for the treatment. This is a case of rheumatoid heart disease. Pneumococcus was the most common cause for meningitis, and it was the most common cause for another thing, that is going to be your pneumonia. अगर कोई भी पूछे pneumonia और meningitis, most common cause is going to be your pneumococcus, right? This is what we have studied, right? Next question we are having, I think last from this CVS part, right? Yes, last question from CVS, try to answer. A 62-year-old female, known case of CCHF, that is going to be chronic compensated congestive heart failure. Patient is presented to you with the reduced ejection fraction. All of the following drugs can be used in this case to prevent the mortality except. So what do you suspect? What is the diagnosis in this particular case? What is your diagnosis here? So this is a case of heart failure. This is a case of heart failure. We already know it is a chronic compensated heart failure. Heart failure मतलब failure is not permanent. So failure मतलब क्या हुआ sir? Heart is not pumping the blood effectively. Heart is not pumping the blood effectively. If heart is not pumping the blood effectively, what is going to happen? You are going to have heart failure, right? Heart के ऊपर pressure पड़ेगा. So in acute heart failure, what you are going to do in acute CHF, what you need to do, acute cases में क्या होता है बेटा, you will be having increase in the you need to do what, you need to do, heart काम नहीं कर रहा, अच्छे से pump नहीं कर रहा. If the heart is not pumping well, what you need to do, you need to increase the contraction, you need to increase the contraction power of the heart. Second thing what you need to do, you need to decrease the fluid, क्योंकि क्या होगा वहाँ पर fluid इकट्ठा हो जाएगा, right? If you want to see, look here, this is your heart, this is your right atrium, this is your right ventricle, left atrium, left ventricle, right? Now what is happening, suppose left sided heart failure है, तो क्या होगा, लेफ्ट वेंट्रिकल ढंग से पंप नहीं करेगा. लेफ्ट वेंट्रिकल पंप नहीं करेगा तो क्या लेफ्ट एट्रियम पंप करेगा? नहीं करेगा. और लेफ्ट एट्रियम ढंग से पंप नहीं करेगा तो व्हाट विल हैपन, ये तुम्हारे लंग्स होते हैं ऊपर, तो लंग्स के अंदर क्या हो जाएगा, लंग्स के अंदर पानी भर जाएगा, राइट? एंड दिस पेशेंट विल बी प्रेजेंटेड विद द सिचुएशन ऑफ डिस्पनिया. इसको सांस लेने में दिक्कत होगी. ही विल बी हैविंग प्रॉब्लम विद द ब्रीदिंग, और ये अपने पास में आएगा विद द लेफ्ट साइडेड हार्ट फेलियर. राइट साइडेड में क्या होगा, द फ्लूइड विल गेट एक्यूमुलेटेड इन द लिवर, राइट? ही विल बी हैविंग हिपैटोस्प्लीनोमेगेली, यहाँ से तो ब्लड आता है, सो इट विल बी गेटिंग एक्यूमुलेटेड इन द लिवर, right? So you will be having hepatosplenomegaly in the cases of right sided heart failure. In the cases of left sided heart failure, the pani will get accumulated in the lungs, right? That is going to be the problem, right? So what we need to do, we need to decrease the fluid, we need to increase the contraction power of the heart, right? So this is going to be the treatment. Decrease fluid करने के लिए, the drugs you are having, these are going to be your diuretics, okay? And increase contraction के लिए we are having drugs, these are known as inotropes. Ino मतलब ion contraction कराता है, inotropes drugs will be there, right? What is the drug we are having? The name of the drug is going to be your dobutamine. डोबूटामीन क्या करता है, बीटा वन एगोनिस्ट है, बीटा वन रिसेप्टर को एक्टिवेट करेगा, और बीटा वन के तीन काम है, एसए नोड, एवी नोड और मसल, तीनों को एक्टिवेट करेगा. एसए नोड क्या कर देगा, हार्ट रेट बढ़ाएगा. AV node is going to do increase in the conduction, and muscle is going to do increase in the contraction, right? So you will be having more heart rate, more conduction, more contraction, and your heart will be working fine. मतलब power दे देगा heart को. Dobutamine is just like the motivation, right? So what it will be doing, it will increase the power, right? Second thing, in chronic और compensated CHF में क्या होता है, ये कहानी अलग है. यहाँ पर हम सब यूज में लेते हैं. बट क्रॉनिक और कंपनसेटेड CHF, व्हाट द क्वेश्चन इज आस्किंग टू अस, कंपनसेटेड CHS में रेनिन एंजियोटेंसिन एल्डोस्टेरोन सिस्टम कंपनसेट कर देता है. दिस सिस्टम विल गेट एक्टिवेटेड एंड इट विल कंपनसेट द थिंग्स, राइट. सो हाउ इट विल compensate and what we are going to do for the treatment, look here. So it will decrease the workload. First thing, it will decrease the workload. Okay, what we need to do, first thing, we need to decrease the workload, right. We need to decrease the workload. Second thing, what we need to do, we need to decrease the fluid which is getting accumulated. Third thing, we need to decrease the left ventricular hypertrophy. ये पेशेंट मरते क्यों हैं? ये पेशेंट मरते हैं, यू मस्ट हैव सीन सम पेशेंट, वो 2 मंजिल सीढ़ी चढ़ते हैं तो वो थक जाते हैं, सांस भर जाती है. दीज आर द पेशेंट्स विद रिड्यूस्ड इजेक्शन फ्रैक्शन, राइट. मतलब हार्ट ढंग से पंप नहीं कर रहा, राइट. दैट इज हार्ट फेलियर. And what we need to do, we need to increase the contractility of the heart, increase the contractile power of the heart. And what are the drugs we are going to use to decrease the workload? We are going to use what? To decrease the workload, I'm back, right. So to decrease the workload, we are going to do what? We are going to use vasodilators. We are going to use what? Vasodilators. To decrease the fluid, we need to remove the fluid. To remove the fluid, we are having what? We are having drugs like diuretics, राइट. एंड टू डिक्रीज द लेफ्ट वेंट्रिकुलर हाइपरट्रॉफी को कम करने के लिए क्या करोगे? एल्डोस्टेरोन एंटागोनिस्ट दे दोगे. द ड्रग्स विच वी आर यूजिंग, दीज आर योर एल्डोस्टेरोन एंटागोनिस्ट, right. And how we can increase the contractility? The drug of choice is going to be digoxin, because digoxin is the only drug we are using for the like oral drug that we are using in the cases of this particular as a inotrope, right. So these are the things we are going to do, right. Now let's try to understand what is the meaning of this compensation. देखो क्या हुआ, basically there is decrease in the cardiac output. कार्डियक आउटपुट कम हो गया, हार्ट में से ब्लड जाना कम हो गया, राइट. अगर ब्लड जाना कम हो गया तो बॉडी विल एक्टिवेट योर सिंपैथेटिक नर्वस सिस्टम. एक्टिवेशन ऑफ सिंपैथेटिक नर्वस सिस्टम विल लीड टू रिलीज ऑफ एड्रेनलिन, नॉर एड्रेनलिन, राइट. बहुत सारा एड्रेनलिन, नॉर एड निकलेगा तो क्या होगा? इट विल बी गोइंग टू योर बीटा रिसेप्टर. So it will be doing activation of our beta receptors. And remember this beta receptor, SA node, AV node and muscles, everything will be getting activated. You will be having increase in heart rate, increase in conduction, increase in contraction. Everything will be increased, right. Now what do we want here? What is the problem that will happen over here? This beta 1 receptor are present at two places. One is your heart and second is in your kidney, right. This is your kidney, and kidney, it will be leading to release of renin, and this is the renin which is going to be responsible. Kiska answer? I'm discussing, just give me some moment, you will be able to understand, right. We are having this renin, and this renin is going to come out from the kidneys, right. And this renin is going to do what? It is going to convert your angiotensinogen which is coming from the liver, okay. Angiotensinogen is going to convert into angiotensin 1, and right, this renin is going to convert into angiotensin 1. Now this angiotensin 1 is going to convert into angiotensin 2 with the help of this ACE enzyme. And remember, these are the ACE enzyme which are the site for COVID-19 binding. COVID-19 का virus जहाँ bind कर रहा था, this is the particular site, right. So what is going to happen? This is going to do what? This particular thing, right. Now what is going to happen? This angiotensin 2 is going to activate your adrenal glands, और एड्रेनल ग्लैंड्स में भी कॉर्टेक्स के पास में जाएगा. दिस इज योर प्रीवियस ईयर क्वेश्चन, लास्ट ईयर क्वेश्चन. एड्रेनल कॉर्टेक्स विल रिलीज व्हाट? दैट इज गोइंग टू बी योर एल्डोस्टेरोन, and aldosterone is going to come to your kidney and it will do reabsorption of sodium and water. Remember, I have told you this is the aldosterone which is going to come and it is going to make E-neck channel, and whenever you are having E-neck channel, what is going to happen? It will absorb lots of sodium, and sodium is like a beautiful girl and water is like the boys, right. So what is going to happen? Water will definitely follow, right. So you will be having accumulation of salt and water, you will be having sodium and water retention. So what is happening naturally? Sodium and water retention हो रहा है. ठीक है, हार्ट फेलियर पहले से है, सोडियम और वाटर रिटेंशन हो रहा है बॉडी के अंदर, व्हाट विल हैपन, मोर लोड ऑन हार्ट, ज़्यादा लोड पड़ेगा हार्ट के ऊपर, हार्ट क्या करेगा, दिस एल्डोस्टेरोन इज ऑल्सो रेस्पॉन्सिबल फॉर लेफ्ट वेंट्रिकुलर हाइपरट्रॉफी एंड दिस इज द रीजन फॉर डेथ ऑफ द पर्सन, इसकी वजह से बंदा मरता है. नेक्स्ट थिंग व्हाट इट इज गोइंग टू डू, इट इज गोइंग टू गो ऑन द ब्लड वेसल्स एंड इट इज गोइंग टू डू vasoconstriction that will in turn lead to BP, increase in the BP. So complete story समझो एक बार, छोटा सा recap देता हूँ, then we will be discussing about the drugs. What is happening in the compensation part. नॉर्मली एक्यूट में क्या हो रहा था, एक्यूट CHF में फ्लूइड तो भर गया था और कार्डियक आउटपुट कम हो गया था, राइट, वो एक्यूट हो गया. क्रॉनिक में क्या हुआ, जैसे ही कार्डियक आउटपुट कम हुआ, ये बीटा रिसेप्टर एक्टिवेट हो गए और इन बीटा रिसेप्टर ने क्या किया, काम संभाल लिया पूरा. दिस बीटा रिसेप्टर had done what, they have increased the heart rate, they have increased contraction, they have increased renin, and in turn what is happening, that is leading to left ventricular hypertrophy, and that is the main reason why the people are dying. So if we want to stop this particular thing, what are the drugs you can use? Okay, so first drug that we can use is definitely going to block this particular thing, that is going to be your beta blocker. तो मैं नहीं चाहता है कंपनसेशन बॉडी करे, तो फर्स्ट थिंग आई एम गोइंग टू यूज इज बीटा ब्लॉकर, any drug metoprolol, that is going to be very effective, right. Second thing, I can block this particular renin, I can block this renin, and what is the drugs that is going to block this renin, that is going to be your aliskiren, right. I can block this angiotensin converting enzyme with the help of drugs like ACE inhibitor. These are the drugs which are having prils, captopril, lisinopril, enalapril, these are the pril group of drugs. Then I can block these receptors, I can block this receptor, angiotensin receptor blocker I can use. These are the drugs which are having sartans, telmisartan, low sartan, valsartan, these are the sartans, right. So what I want, I just want to block this aldosterone ultimately. I don't want left ventricular hypertrophy. I can ultimately use the drug that is going to block this aldosterone, and that is going to be your spironolactone, potassium sparing diuretics, right. So these are the drugs we are going to use in the chronic compensated congestive heart failure, right. But now try to solve the question, because in the question it is written chronic compensated congestive heart failure, so you cannot use which of the following drug. Can we use furosemide? Yes, in the chronic cases also we are having pressure on the heart, so we can use furosemide, right. Can we use angiotensin receptor blocker? Yes, we can use angiotensin receptor blocker because we don't want to have left ventricular hypertrophy. Can we use ACE inhibitor? Yes, definitely we can use ACE inhibitor. They are going to prevent the left ventricular hypertrophy. But can I use the dobutamine? No sir, dobutamine I don't want to use. Dobutamine is a beta 1 agonist. Dobutamine is a beta 1 agonist, and already beta is working very fast. Beta is working very high, right? I don't want that dobutamine here. So dobutamine you are only going to use in the cases of acute CHF, not in the cases of chronic CHF. You got my point, right? So that is the main aim of the treatment. Heart failure में acute cases में you are going to increase the contractility with the dobutamine or isoprenaline or something like epinephrine, right. But the most selective that you will be using is going to be your dobutamine, right. Next thing, you want to decrease the fluid, that is going to be your diuretics, right. All right, now next question we are having from the rheumatology, try to answer. A 40-year-old female patient is presented to OPD with the rashes over the face, sparing the nasolabial fold, right, along with the pain in the joint, that is arthralgia, okay, photosensitivity, and positivity for ANI, positivity for anti-nuclear antibodies, right, was noted for noted. Which of the following is the most suitable cause here? Diagnosis क्या होगा? So this particular patient is having rash, and what kind of rash? Sparing the nasolabial fold. Very good guys, that is going to be your butterfly rash, also known as malar rash, right. And this diagnosis that you want to make over here is going to be nothing but your diagnosis of systemic lupus erythematosus, SLE, right. So in this case your answer will be SLE, but let's try to understand what is this SLE, what is Sjogren syndrome, what is dermatomyositis and Raynaud's phenomena. All these things are important. Let's try to grab up these things, right. So first thing we are having is systemic lupus erythematosus. What is the mnemonic? That is going to be your I am damn sharp, right? Lupus diagnosis mnemonic, that is going to be your I am damn sharp, right? What are the things we are having? It will be having immunologic phenomena. Immunoglobulins will be there. What are the antibodies? Anti-DS, anti-Smith, anti-phospholipid. I'm going to make you right. Next thing is your malar rash will be there, or discoid rash. Anti-nuclear antibody should be there. Mucositis, you can have ulcers in the mouth, and for neurological disorders can be there. Serositis can be there. Hematologic changes can be there. Arthritis can be there, and renal diseases, lupus nephritis, along with the photosensitivity. That is going to be anything you can remember. You are also having another mnemonic like MD, so brain, whatever you want to remember, you can remember, right? So just you need to remember. What is this hematologic cytopenias? This is going to be your anemia of chronic illnesses, AIHI, right? So that is going to be the thing. On kidney biopsy, very important things I am writing. Kidney biopsy, you will be finding which lesions? Wire loop lesions. Wire loop lesions will be there on kidney biopsy. Apart from that, on immunofluorescence, you will be getting a specific type of effect that is known as full house effect. Full house effect, very very important previous year questions. On immunofluorescence, you will be getting full house effect. And what is the criteria we are going to use over here? First of all, we will be checking the anti-nuclear antibody. If the titer are coming positive more than like 1:80, then we are going for a criteria that is known as Euler ACR criteria. Euler ACR criteria, right? And if we get more than 10 points, if a score is more than 10 points, then we are going to make the diagnosis of systemic lupus erythematosus, right? And what is the type of endocarditis we are going to have over here? Here we are going to have which kind of endocarditis? That is going to be your Libman-Sack endocarditis. Libman-Sack endocarditis. And remember, this particular thing can also happen because of drugs, right? So they have made a case scenario in the previous exam, and they have asked you that particular patient is there, he is a TB patient, and TB patient is taking which drug? That is isoniazid. So isoniazid can also cause SLE, right? So what they have written, these are the drugs, ship drugs. Remember, these ship drugs, these can cause SLE, right? So as for sulfonamide, if someone is taking sulfonamide, maybe it can be a dapsone, right? Sulfonamide. H for hydralazine, I for isoniazide, and P for procanamide. So these are the drugs which can cause drug induced SLE, right? These are the things you have to remember. What are the antibodies we are going to have? Very very important thing from this antibodies that we are having is ANA. What is ANA? It should be positive. Most important antibody is ANA, and it is highly sensitive. It is highly sensitive, but specificity is not that much, so it will be having low specificity. It will be having low specificity, right? It is very sensitive, but specificity is low. Okay, whereas this double stranded DNA, dsDNA, is highly specific. It is going to be highly specific, and it will also correlates with the disease activity. It will also correlates with the activity of disease, right? Anti-Smith antibodies, they are the specific ones. Okay, anti-Rho, anti-La, these are going to be non-specific. इनको हम कहीं और पढ़ेंगे. I'm going to teach you somewhere else, right? Next is the anti-histone antibodies seen in the drug-induced SLE. Anti-histone antibodies, and right, we are having this anti-phospholipid antibody. This is going to be seen against cardiolipin or beta-2 glycolipid. Cardiolipin or beta-2 glycolipid. Okay, yes, we are going to see anti-Rho, anti-La in the cases of there, right? So what is this? Another thing that we are having is Raynaud's phenomena. Raynaud's क्या होता है? And what is the sequence of primary Raynaud's? So Raynaud's phenomena में sequence क्या होता है? Yes, anticardiolipin antibodies are found in the heart, right? What is the sequence for Raynaud's phenomena? The sequence is going to be WBR. White color is due to vasoconstriction. B is your blue color. Blue color is due to ischemia. And R is the red color, that is due to hyperemia or regain of the supply. Regain of supply. Right? So that is going to be the Raynaud's phenomena. We can have primary Raynaud's, we can have secondary Raynaud's. Okay, tell me which one is going to have ulcer, primary Raynaud's or secondary Raynaud's? This is your previous year question. Primary Raynaud's, remember, it has no association with connective tissue diseases. It has no association with other diseases, the other disorders, right? And it is going to be A negative. It is going to be negative for the anti-nuclear antibody. Whereas the secondary Raynaud's, this is your PYQ, secondary Raynaud's, it has association with the scleroderma and other diseases also. Scleroderma, right? I'm going to teach you what is scleroderma and certain drugs. And it is also positive for the ANA. Okay, it is also positive for the ANA, and it can also cause gangrenes. So they have given you question, it can also cause gangrene. So they have given you question that patient is having the gangrene, and now what is the related thing? So that is going to be your secondary Raynaud's, which is going to be responsible for the gangrene, because in the option you are also having the primary Raynaud's, and the sequence was same, white, blue, red. That is the same sequence. So you have to remember secondary Raynaud's can cause gangrene and other diseases, whereas this primary is no association with the ANA, no other disorders, right? What is this particular thing? Try to see and identify what is this particular disease will be there. What are the things which are involved over here? Look here, there is involvement of derma, myo means muscle, cytis means inflammation. So it is going to have inflammation of muscles and skin, right? Involvement of skin and muscles. And here you will be having which kind of muscle involvement? That is going to be your proximal muscle involvement. Proximal muscle involvement will be showing you which sign that you also see in the that you also see in a disease. Proximal muscle weakness that you also see in a disease, Duchenne or Baker's muscular dystrophy, right? So you will be having a sign that is known as Gower sign. Gower sign is also going to be positive over here, right? What are the things you have to remember? It is going to increase your CKAM levels, right? It is going to have association with the anti-MDA5, anti-MDA5, anti-TIF1. They can give you question all except, they can give you question all except anti-MDA1, anti-TIF1 and anti-MI2, right? These are the associations, right? Here you will be having this heliotrope rash. Heliotrope rash means there will be a rash around the eyes. Here you will be having this shawl sign. जहाँ shawl उड़ते हैं वहाँ पर एक sign होगा. You will be having these papules. These are known as Gottron's papules. Gottron's papules derma में पढ़ा है मैंने, right? And this is going to have calcinosis cutis. There will be hardening, mechanics hand type. Stratum corneum की thickening हो जाएगी यहाँ पर, right? So that is going to be your dermatomyositis. That is going to be your dermatomyositis. How you will do the identification? So for identification, the investigation of choice is going to be your MRI guided muscle biopsy. MRI guided muscle biopsy. The investigation of choice is going to be your MRI guided muscle biopsy, where you will be finding perifascicular atrophy. Very, very important. This is your previous year question, right? So MRI guided muscle biopsy will be done in the cases of dermatomyositis, and you will be finding what? Perifascicular atrophy, right? Next thing we are having is Sjogren syndrome. Sjogren syndrome, Sicca syndrome, dry syndrome. You will be having what? You will be having multiple places dryness will be there, right? You will be having dryness in the mouth, that is known as xerostomia. Dry gutty sensation on the eyes, that is going to be your dry gutty eyes. It is more common in females as compared to males, and it is going to be positive for the anti-nuclear antibody. These are the keywords I am teaching you, right? What are the antibodies which are going to be positive? That is going to be anti-Rho, also known as anti-SSA, anti-SSA, or anti-La antibody, that is going to be anti-SSB. These are the antibodies which are going to be positive in the cases of Sjogren. One more question they have asked you. And I said they have asked you, it has association with the HLA DR3. It has association with the HLA DR3, right? It has association with the HLA DR3, right? Next thing, how you are going to manage this particular patient? You are going to give symptomatic treatment. Like for example, this patient is having dryness in the eyes, you can give artificial tears. Like if this patient is having xerostomia, you can contract the glands with the help of a drug. What is the name of the drug that is going to be used in the xerostomia? Anyone? Symptomatic treatment you can give. You can use drugs like savimeline. This is also a PYQ, right? So these are the things you can do. So now we know about the Sjogren syndrome. Now we know what is dermatomyositis. Now we know what is Raynaud's, primary Raynaud's, secondary Raynaud's, and these are very, very important. Okay, SLA antibodies, and these are the basic classification, and these are all important things that I've told you, right? Kidney biopsy, immunofluorescence, all of these things are already been asked, right? This EULAR SCR criteria is also very important, right? So here the answer in this particular case is going to be your D. Answer is going to be your D, right? Next question that we are having, right answer: a 32-year-old female patient is presented to OPD. What are the complaints this particular female is having? She is having symmetrical skin thickening. Symmetrical skin thickening. Okay, and contractures in the hands. And on the radiographic examination of the the presence of fibrosis in the lungs. Lung fibrosis. Lung fibrosis are noted. What are the probable diagnoses in this particular case? What is your diagnosis here? So your diagnosis here is going to be what? Try to answer. What is your diagnosis here? Very good, Sheikh. That is going to be your scleroderma. That is going to be your scleroderma. Look here. So this is your diagnosis, scleroderma. So how many types of scleroderma is there? What is the meaning of sclero? Sclero means hardening, sclerosis. That means hardening or thickening, right? So scleroderma मतलब क्या हो गया? There will be thickening of skin. There will be thickening of skin. And beta, it will be of two types. We can have diffuse type, we can have limited. We can have limited scleroderma, we can have diffused scleroderma. Diffused or limited, right? Limited जो scleroderma है, that is also known as crest syndrome. That is also known as crest syndrome. Crest syndrome, right? So this is going to be the important thing, right? Now, what are the things you will be having in the crest syndrome? Look here. Crest में क्या क्या होगा? Limited में क्या क्या होगा? You will be having calcinosis, calcium deposits on the skin. That is going to be calcinosis cutis, right? So that is going to be your calcium deposited on the skin. R4, you can have Raynaud's phenomena. What kind of Raynaud's? Primary or secondary? Remember, it will be secondary Raynaud's phenomena. Just now we have seen, right? Third thing, esophageal dysfunction will be there. It is a differential diagnosis for one disease, that is going to be your achalasia cardia. Achalasia cardia, bird beak appearance will be there. Okay, bird beak appearance will be there. Next thing is going to be your sclerodactyly. Sclerodactyly means there will be thickening and tightening of the skin on the fingers and hands, right? That is going to be your sclerodactyly. Dactyly matlab fingers, right? And there will be telangiectasia. That is going to be the dilatation of the capillaries of the skin. Okay, so that is going to be the crest syndrome, which is going to have limited scleroderma, right? So this is going to be your crest syndrome. In the cases of diffuse में देखो क्या क्या होगा. Diffuse में there will be certain things which are going to be more, like diffuse will be having what? Arthritis. Yes, there will be more arthritis in the diffuse, right? It will be having friction roughs will be there. That is going to be more. Pulmonary fibrosis, more risk will be there, just like our case is having pulmonary fibrosis, right? And these are the antibodies which are going to be positive. Anti-SCL70 is going to be more positive for the diffuse type, whereas this anti-centromere antibodies are going to be more positive for this particular thing, that is going to be for the limited type, right? Apart from this, we are having what, how you are going to make the investigation of choice that you are going to do. You can do antibody testing. What are the antibodies that are going to be positive here? SCL70, that is also known as anti-topoisomerase antibody. And second one that we are having is going to be your anti-centromere antibody. देखो कोई सा भी हो, diffuse हो, limited हो, what is the thing we want? We don't want all these complications in our body. So the drug of choice here in this particular case is going to be your steroids, right? Steroids दे दो patient को, and that is going to be your the thing. Most important, most specific I am talking about, right? So that is going to be the steroid, right? What about this ankylosing spondylitis? Let's finish it off here. Ankylosing spondylitis में क्या question पूछेंगे तुमसे? They will be giving you history of a young man. There will be a young male patient, एक young male patient देंगे who will be having pain on the back, back. There will be low back ache will be there, right? And this pain will be more in the morning. So this pain will be more in the morning, and this pain will subside as the day passes, right? So this pain will subside on activity, improves with activity. And remember, very very important, it has association with HLA B27 के साथ में, और ऑर्थो में पढ़ा होगा, रेडियो में पढ़ा होगा. What are the appearances you will be getting on the MRI? You will be getting, very nice, that is going to be your, bolo, that is going to be your bamboo spine appearance, or dagger sign appearance, bamboo spine appearance, right? Very good. It will be having sacroiliitis will be there. And how you are going to treat this particular situation, the treatment we are going to discuss, that is going to be your non-steroidal anti-inflammatory test. Non-steroidal anti-inflammatory test we are going to do, right? So that is going to be your ankylosing spondylitis. What about this Behçet's disease? Which one is left? Dermatomyositis we have already seen, right? So what is going to happen in the Behçet's? Let's make a short note about it also. So in Behçet disease, you will be having what? Recurrent oral ulcers will be there. Recurrent oral ulcers will be there. Along with the oral ulcer, you will also have genital ulcers, which are going to be painful. So you will be having painful genital ulcer. You can have involvement of eyes, that is going to be uvea. So you can have complete uveitis, and you can also have erythema nodosum. These are the important points. I'm telling just the keywords. Erythema nodosum, right? And its association has been asked. So it is associated with HLA-B5 and HLA-B51. It is associated with HLA-B5 and HLA-B51. One question they have asked on the treatment, the normal treatment that we are giving, that is going to be your steroids. But apart from that, one more thing we are going to do, that is going to be your apremilast. That is going to be the treatment. This is important, you have to remember this. And one test that we are doing for this particular thing, Behçet's, that is going to be your pathology test. It is going to be positive for the pathology test, right? So these are the important points as far as this Behçet's is concerned, right? This is the information you should be having just before your exam, right? Itna to hona chahiye, right? So the answer for this particular question is going to be scleroderma. And if we go in detail, that is what kind of scleroderma is going to be. Is it diffuse or limited? Is it going to be diffuse or limited? Try to answer, right? Next question we are having is going to be your 45-year-old male patient is presented to OPD with the complaints of pain, joints, pain in the joints, most commonly in the metacarpophalangeal joints, MCP and PIP, right? And this stiffness is usually fade away as the day progresses. So he is having the morning stiffness. What can be the most likely diagnosis in this case? So what is your diagnosis in this case? Yes, very good question. What is your diagnosis in this particular case? So this is a case of morning stiffness is there, small joints are involved, MCP, PIP. Your diagnosis is going in the favor of what? Very good. Good try, Saloni. So whenever we are having involvement of MCP, PIP and morning stiffness, morning stiffness, morning stiffness is a feature you are going to find with the cases of, very good, Dr. Izzy, that is going to be rheumatoid arthritis. Rheumatoid arthritis. Rheumatoid arthritis, and it has association with what? It has association with HLA. It has association with HLA DRP1, right? So that is going to be your rheumatoid arthritis. What are the important points about arthritis? Rheumatoid arthritis, पेन कैसा होगा? मॉर्निंग स्टिफनेस होगी, मॉर्निंग में पेन होगा, bilateral involvement will be there, right? So you will be having bilateral joint involvement, and this pain will be on the small joints. Majorly this pain will be involving the small joints, bilateral involvement, and these pains, this pain is going to be more in the morning. So you will be having this morning stiffness things I have already written, and this pain will be resolved as the day passes. जैसे जैसे दिन बढ़ेगा आगे, you will be utilizing your fingers and all those things. What will happen? The pain will fade away, right? So it will improve on exercise or activity. Improve on exercise or activity. This is the pain which will be improving on exercise or activity, right? You will be having this classical word. Remember this classical word, that is going to be your morning stiffness. So you will be having this morning stiffness. How you are going to do the screening for this particular thing? What is the test we are going to do? Okay, what is the test we are going to do? What is the test we are going to do here? Rheumatoid में RA factor करेंगे, which is the screening test we are going to do. That is going to be RA factor. And what is the investigation of choice? यहाँ पर हम लोग करते हैं anti-CCP antibodies testing. Anti-CCP antibody testing. Okay, anti-CCP antibody testing is going to do. Right? Drug of choice क्या है यहाँ पर? Drug of choice or treatment of choice, you can say DMARDs, disease modifying anti-rheumatic drugs. DMARDs will be the drug of choice here, right? Apart from that, you can have some deformities also from ortho. If you want to connect ortho or radio, you will be having swan neck deformity, swan neck. You can have Botaniers, you can have Z-line deformity. So all these things are going to be seen in this particular case. ठीक है, तो ये एक elderly, एक normal middle-aged person होगा. He will be having joints, he will be having pain more in the small joints. Rheumatoid arthritis का patient कैसा होगा? More in the small joints, and this pain will be more in the morning, and this pain will fade away as the day passes. जैसे जैसे वो काम करेगा, this pain will fade away. You will be doing the screening test with the RA factor. Family में चलता है. If someone is having, father is having, there is more chances the boy will have or the girl will have, right? And second test that we can do is the anti-CCP test. Drugs जो चलती है, they are known as DMARDs or SARDs, slow acting anti-rheumatoid drugs, right? They are going to be, we do not have as such permanent cure for this particular disease. We can do what? We can decrease the progress of the disease. Like we are having, what are the drugs which are included here? And in fact the drug of choice is going to be methotrexate, which is in fact a anti-cancer drug, but we are using here in this little doses, right? Little doses, like HCQS also we are using, right? I'm not going into pharma parts, but we are having this methotrexate, HCQS. These are the drugs we are going to use here to delay the disease, right? इसका हमको course delay करना है. That is what we are doing in the in the rheumatoid arthritis. Now let's talk about the osteoarthritis. बाकी क्या क्या है अपने पास में? Osteoarthritis. Osteoarthritis, how you can assess? Generally the pain will be in the knee joint. And why this pain is happening? Why this pain is happening? Because of decrease in the synovial fluid. decrease in the synovial fluid. When you are going to do the x-ray of this particular thing, you will be finding that there will be reduced joint spaces. There will be reduced joint spaces, and now what is happening, it will be rubbing with each other, and that is what is going to cause the pain, right? So that is what is happening in the cases of osteoarthritis. In x-ray or radiograph, you will be finding reduced joint spaces, reduced joint spaces. नॉर्मली अगर वहाँ पर फ्लूइड होगा, कार्टिलेज होगी, तो स्पेस दिखेगा, बट हियर टू बोन्स अगर आपस में जुड़ी हुई दिख रही है, दैट मीन्स व्हाट इट इज गोइंग टू बी योर osteoarthritis. What is going to happen? One most important thing about this is due to GDF5 polymorphism. Most important point that you have to remember about osteoarthritis, right? Next thing we are having is gout. What is that gout? तो gout का केस कैसे आएगा? There will be a middle aged man, there will be a middle age alcoholic person will be there, who is eating dry fruits or something like rich in proteins and nucleic acid, right? So he will be a middle-aged businessman person, alcoholic person will be there, right? And he will be coming to you with increased levels of uric acid. Uric acid will be more, and in that particular uric acid, apart from that, you will be having inflammation. You will be having inflammation on greater toe, inflammation of the greater toe, or you can also call it first, they can also write like inflammation of the first MTP joint, metatarso-pharyngeal joint, right? This is what they can write you, right? So that is going to be the presentation. Yes, that these can be the presentation for the gout. There will be inflamed red toe, right? This can be the presentation of the gout, right? How you are going to do the diagnosis? So when you are going to check for the uric acid levels, when you are going to do the uric acid levels, you will be having high levels of uric acid. Second thing, you can also do joint aspiration. So you can take the sample, you can take the synovial fluid, joint aspiration, and you can look for the aspiration, and you can look for the sample, right? You will be finding here which kind of crystals you will be having. Negatively, very important question, negatively birefringent, needle shaped crystals will be there. I am going to show you the image. सारे stones पढ़ेंगे. When we are going to discuss all the stones together, I'm going to show you the image, right? So you will be having this type of crystals will be there, right? For the treatment part, if I want to talk for acute cases, the drug of choice will be NSAID. Indomethacin is the drug of choice we are using. कौन सी यूज में नहीं लेनी है? That is going to be aspirin, because aspirin can cause hyperuricemia. Apart from aspirin, your drugs like diuretics, they can cause hyperuricemia. Apart from that, you are also having drugs like niacin that can also cause hyperuricemia. So all these drugs which are causing hyperuricemia, you should be avoiding in the patients of gout. Apart from that, the most effective drug that you can use is going to be your colchicine. The most effective drug is going to be your colchicine. Okay, allopurinol अभी बताता हूँ कब यूज में लेना है. In the cases of acute gout, we are not going to use allopurinol. Let me make you understand what is this chronic gout. Chronic gout में क्या होगा? This uric acid is the end product of nucleic acid. Uric acid is the end product of nucleic acid. What are the nucleic acid we are having? Like purines, pyrimidines, right? So it is the nucleic acid end product, that is we are having xanthine, and this xanthine is going to make what? It is going to make uric acid. Xanthine is going to make what? Uric acid with the help of an enzyme that is known as xanthine oxidase, right? Now what we can do, if I want to decrease this uric acid, I can block this enzyme, right? So I can use drugs which are going to be xanthine oxidase inhibitor. These are going to be your allopurinol. These are going to be your febuxostat, exostat, right? Xanthine oxidase stat, right? Then second thing I can do, I can decrease this thing is getting excreted in the urine. Right, so what I can do, I can increase the excretion by adding drugs like probenecid. Okay, we can use lesinurad, we can also use sulfenpyrazole, right? So these are the drugs which are going to increase the excretion. Next thing, what will happen in the birds, we are having this particular thing, uric acid is going to convert into allantoin with the help of an enzyme which is known as uricase, right? So I can give in the humans also I can give some drugs which are uricase analog, and these are going to be your ras buricase. नाम में ही लिखा है यूरिकेस, so its name is having uricase, rasburicase, pagloticase, right? So these are the drugs we can use in the cases of these are going to alter the uric acid and convert it into allantoin, right? Which is a foam which can easily go out. Okay, gout clear है, gout में कोई doubt नहीं है, right? One more question they ask you, gout के साथ में pseudo gout क्या होता है? What is pseudo gout? Pseudo gout, same presentation will be there, but the patient will be elderly patient. Now the patient will be elderly patient will be there who is having the knee involvement rather than first MTP. Here the involvement will be knee involvement will be there. Okay, knee involvement will be there. Apart from that, here you will be having crystals, but these crystals are made up of what? These are rhombic crystals I'm going to show you, and these crystals are made up of calcium pyrophosphate. These are the crystals which are made up of calcium pyrophosphate. Okay, so these are the things about the rheumato part. Important part of the rheumato I've covered. Right now we are going to discuss a question on the nephrology. The question we are having is, a 8-year-old boy is presented to OPD with the complaints of, 8 साल का बच्चा है, उसको क्या complaint है? He is having complaints of facial edema. Facial edema is there, and the frequency of urination is decreased, that is oliguria is there, right? And cola color urine से क्या समझ में आता है बेटा? Is coming on examination, the proteinuria is noted, which of the following is will be the appropriate diagnosis in the given picture. So what do you think is the diagnosis here? Yes, we can use Saloni. Good Kusum. Right, so what is the thing we can do in this particular case? So is it a nephrotic syndrome, acute glomerulonephritis? Is it a focal segmental glomerulosclerosis, or Berger disease? Let me make you understand. We are having two important things. One is your nephrotic syndrome, another one is nephritic syndrome. देखो दोनों में difference क्या है? Pro. It's like a pro. Nephro is like a pro. So you will be having proteinuria in the nephrotic syndrome. You will be having what? You will be having more proteinuria in the nephrotic syndrome, whereas nephritic will be having what? Nephritic will be having proteinuria along with hematuria, right? Just see, just go through this table and you will be able to understand what are the things we are having, right? So first thing, you will be having what? Low serum albumin in the nephrotic syndrome. I have told you, albumin गया बॉडी में से, albumin गया तो क्या होगा? ब्लड पतला हो जाएगा. अगर ब्लड पतला हो गया तो क्या होगा? बाहर आ जाएगा सेल से और इकट्ठा हो जाएगा. You will be having what? Ascites. You will be having puffiness on the face. You will be having edema. Generalized edema is known as what? Anasarca, right? You will be having generalized edema. Why? Because there is decrease in the albumin nephrotic syndrome मतलब क्या हो गया? देखो, simple understanding, you will be having what? Basement membrane. उसके अंदर क्या हो गया? Basement membrane के अंदर बड़े बड़े छेद हो गए. Now the plasma protein can easily leak out into urine. This is nephrotic syndrome. यहाँ से प्लाज्मा प्रोटीन बाहर चला गया, ये नेफ्रोटिक हो गया. और अगर ये छेद और भी बड़ा हो गया, इफ दिस होल इज मोर बिगर, नाउ व्हाट इज नोन एज, अब क्या होगा? अब आरबीसी भी बाहर चला जाएगा, दैट इज नोन एज नेफ्राइटिक सिंड्रोम. तो सिंपल अंडरस्टैंडिंग इतनी सी है. नेफ्राइटिक में क्या हो रहा है? एक में प्रोटीन यूरिया ज़्यादा हो रहा है, एक में प्रोटीन यूरिया अलोंग विद द हीमोचूरिया हो रहा है, राइट? सो लेट्स ट्राई टू अंडरस्टैंड. सो लो सीरम एल्बुमिन विल बी देयर. Protein urea, कितना protein urea? That is important, more than 3.5 gram per day. Here also protein urea will be there, but mild protein urea will be there, right? Apart from that, you will be having edema, right? Dyslipidemia, lipids खराब हो जाएंगे, right? Hypercoagulable state हो जाएगी because of antithrombin 3 भी बाहर चला गया. Antithrombin 3 is responsible for clotting, right? So responsible to decrease the clotting. Antithrombin 3 क्या है, anticoagulant की तरह काम करता है, right? Next thing we are going to have what? Reduced immunity. You will be having loss of immunoglobulins. Everything is going out in the urine, right? Here also you will be having oligouria. So oligouria is a symptom you will be finding in the nephritic syndrome. You will be having hematuria, and that is the hematuria beta, that is going to cause cola colored urine. Cola colored urine कब आएगा? That means this patient is having what? This patient is having some kind of hematuria. They have already mentioned the frequency of urination is decreased. That means this patient is having what? Oligouria. So these are the signs which are going in the favor of what? They are going in the favor of him, this particular thing, nephritic syndrome, right? Apart from that, we are having what? Here you will be having peripheral edema, that is ascites, right? You will be having facial edema in children. Frothy urine will be there. Fatigue will be there. Recurrent infection can happen, right? What about proteinuria? It will be having more. Hematuria may or may not be present, but it is going to be very markedly present in the cases of nephritic syndrome, right? RBC are going to be present over here, right? So these are the basic differences between nephritic and nephrotic syndrome, right? Now what you need to remember, this minimal change disease is the most common type of nephrotic syndrome that is happening in the children. Minimal change disease is the most common type of nephrotic syndrome that is happening in the children's. Membranous, that is going to be more common in adults, and here you will be finding the spike and dome pattern. पैथो भी रिवाइज हो गया, राइट? स्पाइक एंड डोम पैटर्न, एंड दिस फोकल सेगमेंटल ग्लोमेरुलोस्क्लेरोसिस जनरली seen in adults, FSGS, right? And if it is having association with the HIV, it is going to cause worst prognosis, right? And how you are going to treat this particular thing? For the treatment part, what you need to remember, the drug of choice for nephrotic syndrome is going to be always steroids. But there are some things, right? We are also having steroid resistant nephrotic syndrome. In that particular case, we are going to use tacrolimus, calcineurin inhibitor, like tacrolimus or cyclosporine. In HCV patient, it is going to cause what? MPGN, right? So this is what you need to remember. Most common in children is minimal change disease. Okay, adult or elderly, that is going to be membranous nephropathy. FSGS, if it is associated with HIV, going to give you worse prognosis. The drug of choice is going to be steroids, right? But in steroid resistant, we are going to use calcineurin inhibitor. These are going to be your tacrolimus and cyclosporin, right? This nephritic syndrome is generally associated with the infectious diseases, right? All these symptoms will be there will be hematuria, there will be proteinuria, mild proteinuria will be there, mild edema will be there. But what you need to remember, what are the different things? The first thing that can happen is IgA nephropathy, and this is what is known as Buerger's disease. Buerger's disease is what? IgA nephropathy. Okay, IgA nephropathy. We can also have post streptococcal glomerulonephritis. Now I think you will be able to understand what I want to teach you. This is going to be a type 3 hypersensitivity reaction. It is going to be anti-streptolysin O positive. It is going to be positive for the anti-streptolysin O as well as anti-DNSB. More than 300 toad unit, right? Anti-DNSB positive. And this thing is happening within like 1 to 3 weeks of sore throat infection, right? And what is the drug of choice for this particular case? Again, you will be needing what? Penicillin is the drug you will be using, right? So this is the same story that we have discussed in the cases of RHD. Here also you will be having these symptoms, right? Next we are having is RPGN, that is rapid progressive glomerulonephritis, and here the antibodies will be anti-GBM glomerulonephritis, and ANCA vasculitis will be there, right? So these are the things you should be knowing about these two important things, right? So here in this particular case, your answer will be acute glomerulonephritis. It is not nephrotic syndrome. Why? Because sir, it is also having the hematuria. Why it is not focal segmental glomerulosclerosis? Because sir, it is also a type of what? It is also a type of nephrotic syndrome, right? And Berger's is a IgA nephropathy, right? So the answer here in this case is going to be acute glomerular nephritis. Now try to identify the stone based on the given image below. What is this particular stone? They are asking image based question on this type of questions they are asking, right? Try to answer. So identify the stone on the basis of given image below. What is this particular stone that you are having in front of you? No, Saloni, hypoalbuminuria is a different thing. एल्बुमिन यूरिया मतलब यूरिन के अंदर एल्बुमिन कम जा रहा है, ऐसा नहीं होगा. देर विल बी एल्बुमिन यूरिया, दैट मीन्स एल्बुमिन इज गोइंग अवे फ्रॉम द बॉडी. हाइपो एल्बुमिनीमिया होगा मतलब ब्लड के अंदर कम हो गया, राइट. प्रोटीन यूरिया विल बी देयर एंड यस, प्रोटीन यूरिया मतलब वही एल्बुमिन बाहर जा रहा है, राइट. So what stones are they? Very good, everyone is answering right. So let's try to understand. You are answering me, this is a calcium oxalate stone, right? Is it monohydrate, dihydrate? So calcium oxalate can is the most common stone that we can have. Calcium oxalates are the most common stones that we are having. Most common stones that we are having. We can have two shapes here. One is going to be this enveloped shape. This is going to be like an enveloped shape. This is an enveloped shape. We can also have this particular shape. This is known as what? This is known as dumbbell shape. This is known as dumbbell shape. Dumbbell shape is going to be mono. This is going to be monohydrate, right? Whereas this enveloped is going to be di. Are these stones are going to be pH sensitive? No, they are pH insensitive. They have nothing to do with the pH. Insensitive. They are pH insensitive, right? These are your two stones that you have to remember. First is your envelope shape, that is going to be the same calcium oxalate. Both of them are same, but sometimes you will get the dumbbell shape appearance, sometimes you will get the envelope appearance. This is the most common stone that we are having, right? Second one, we are having this appearance. This particular appearance is known as what? And what is this stone? This stone is basically triple phosphate stone. This is your triple phosphate stone, also known as true white stone. Also known as true white stone. True white stone. And it has association with an infection, an organism that is going to be your proteus. Proteus के साथ में इसका जुड़ाव है, right? And it will be finding generally in the alkaline pH. Alkaline pH. Right? So these are the things you should be remembering about this particular stone. And the appearance will be very good, Kusum. That is going to be your coffin lid appearance. This is going to be coffin lid appearance. This is going to be coffin lid appearance, right? The next stone we are having is hexagonal in appearance. This is your which stone? Hexagonal in appearance. Hexagonal in appearance, right? And this is also H for hexagonal. This is also the hardest stone. This is also the hardest stone that we are having, right? So this is going to be your cystine stone. This is going to be your cystine stone. Cystine wali stone hai, right? Next we are having is this. Next we are having is this. So just now we have discussed about the gout. So when we are discussing about the gout, after that we will take what? Synovial fluid. Synovial fluid लेते हैं. Synovial fluid we have discussed. And synovial fluid you are finding what kind of crystals? These are your needle shaped crystals. These are your needle shaped crystals and they are negatively birefringent. Negatively birefringent crystals, right? These are your negatively birefringent needle shaped crystals and they are made up of what? They are made up of monosodium urate. Monosodium urate. They are made up of monosodium urate, right? These are rhombic crystals that you can appreciate over here. These are your rhomboid crystals. These rhomboid crystals are found where? Rhomboid crystals, they are positively birefringent. They are positively birefringent. Okay, They are positively birefringent. We are also extracting the synovial fluid holes here also. And these are the stones we are finding in the pseudo gout. अब बता दो कौन से स्टोन होंगे pseudo gout में? We have discussed. It will be having, yes, calcium pyrophosphate. It will be having calcium pyrophosphate crystals, right? So that is going to be your pseudo gout. Pseudo gout will be having these rhomboid crystals which is positively birefringent, whereas this particular thing, that is your gout, is going to have which kind of crystals? That is going to be have needle shaped crystals which are negatively birefringent, right? Monosodium urate ke crystals here will be monosodium urate, here you will be having calcium pyrophosphate, calcium pyrophosphate, right? Next question. A type 2 diabetic patient is on norfloxacin, okay, for recurrent fever episodes, and he is also having the hypertension. Patient is also having the hypertension. He is a diabetic patient who was on norfloxacin for recurrent fever episodes. So doctor has started a new drug which helps in reversal of the symptoms. Identify the drug that we are having. Which is the drug we are having here? Yes. So what is going to happen? Let's try to understand what is diabetes first. What is diabetes? We have already discussed it in the physiology section, but yes, we can just do a quick recap, right? So whatever glucose you are eating, whatever rasgulla you are eating, what is going to happen to that rasgulla? Let's try to understand, right? It will be going to your gut, it will be going to your stomach, it will be going to your intestine. After intestine, it will be going to your blood. It will be getting absorbed from SGLT1 or GLUT1, GLUT2, right? It will be getting reabsorbed, and what will happen now? Now it will be you will be having GLUT4. GLUT4 will be responsible for the absorption of glucose. Now what will happen? This glucose will be going to come here. This glucose is going to come into the blood, and when this glucose is going to come into the blood, now this blood is a connective tissue. It will be transporting all around the body, right? So this glucose will be coming to the contact of this particular cell. And what is this cell? This cell is your beta cell of pancreas. This cell is your beta cell of pancreas. Now what is going to happen? This glucose is going to go inside, and you will be having glycolysis. And a product of glycolysis, how many ATPs are formed? There will be 7 ATPs, right? So what will happen with this particular glucose? रसगुल्ला जो खाया था उसके साथ क्या होगा? It will be ultimately making what? Pyruvate, and you will be having formation of 7 ATPs. Now this 7 ATPs will do one thing. They are going to close this particular pump. Here we are having ATP sensitive potassium channel. Here we are having ATP sensitive potassium channel, and once we are closing this particular pump, what is going to happen? You will be having accumulation of potassium inside. And I have taught you, whenever there is a positive charge accumulating inside, what is going to happen? It is going to cause what? It is going to cause depolarization. So this cell is undergoing depolarization. Now because of this depolarization, sir, calcium will come inside. From extracellular fluid, calcium will come inside, and calcium has three functions. It will do, in the vessel it will do vasoconstriction, in muscle it will do muscle constriction, and in the cell it will do exocytosis, right? So whenever this calcium is going to come inside, what is going to happen? You are going to have an insulin vesicle here, right? It will be having insulin, it will be having amylin, it will be having C-peptide, right? So what will happen? As soon as calcium will come inside, this cell will release what? It will release this insulin, right? And now insulin is coming outside, and you already know insulin is a endocrine gland product, right? And endocrine glands will release their substances directly into the blood. So you will be having this insulin in the blood vessel, right? You are having high glucose in the blood vessel, you are having insulin in the blood vessel. Now what is going to happen? Understand the story. This blood will be traveling all around the body. It will be going to a cell, and this cell is going to be your, this cell is having GLUT4, glucose uptake transporter type 4, right? Now this insulin which we have made, this insulin is looking like a key. Just remember, from now it is the key. Now this insulin is going to come over here. It will open the lock, and what will happen? This extra glucose we are having in the blood, it will go inside, right? This GLUT4 is present in your adipocytes. It is present in your skeletal muscle. Okay, it is present in your cardiac muscle. So what is going to happen? The glucose which is coming inside the cell will utilize for the energy. Whatever extra glucose you are eating, extra rasgulla will be making what? Adipocytes. It will be getting stored in the body, right? You will be getting fat because of extra glucose, right? So what is going to happen? It will be utilized. And now we are going to have what? In the blood we are going to have normoglycemia. In the blood we are going to have normal levels of glucose, and that is what we want. Because glucose, till the time glucose is present in the blood, glucose is like a single molecule. A single person will do what? It will destroy the life of others, right? Just like that. Okay, just for the fun, right? So what is going to happen? This glucose, whenever it is going to come in contact with any cell, it will destroy it, right? It will cause problems, right? So that is why we never want glucose in our blood, because if this glucose remain in our blood for longer time, it will even bind with the hemoglobin, and that is what we call it HbA1c, glycated hemoglobin. Glycated hemoglobin means normal half life of normal lifespan of hemoglobin is 120 days, RBC 120 days. But whenever it is going to bind with the glucose, what is going to happen? It will decrease to 90 days. And that is what we are checking for the levels of HbA1c. Is going to tell the, it is going to tell the average sugar for last 3 months, average sugar value for last 3 months. Because what is happening, this glucose is going to bind with the hemoglobin, and now this is known as glycated hemoglobin or glycosylated hemoglobin, right? And that is why this RBC's lifespan has decreased, right? So this is the test we are also doing for the identification, right? We will discuss about that. Now we will be having two types of diseases here, right? First we are going to have type 1 diabetes. Second, we are going to have type 2. Others are the modification of these things like MODI, LADA, all those things, right? I'm going to teach you about the basics first, right? So what is going to happen in type 1? You can make one like a eye, right? You can make one like eye. So this is going to be insulin dependent. Here the problem lies with the insulin dependent. That means we do not have the key. If we do not have the key, if we do not have the key, do you think we can open the door without the key? No, we cannot, right? So we need to have the key, right? And the treatment in type 1 is going to be definitely the insulin, because we are having damage in the beta cells of pancreas, right? We do not have insulin production now, right? So we need to take insulin from outside, and this is what is known as, we need to take insulin as a drug. That is going to be the treatment. The treatment will be insulin. But in type 2, what is going to happen? You can understand 2, I can make it like a R, right? And R is like resistance. So what is happening? We are having the key, we are having the key, but the lock that we are having, is having the problems, right? So we are going to have the problem with the lock, right? If we are having the problem with the lock, what is the lock we are having? This glut for. Now we are having insulin, but this insulin is not able to open up this channel. That is why this glucose is not able to come inside, right? So what we need to do, we need to convert it. What we need to do, we need to change, either we can do what, we cannot change the lock, we cannot change the things, right? So what we can do, we can give the drugs. ताला जाम हो जाएगा तो क्या करोगे? You will put the oil, right? So that is the oil we are putting here. ठीक है? तो ऑयल क्या हो गया यहाँ पर? ड्रग ऑफ चॉइस विल बी metformin. Drug of choice in type 2 will be metformin. Let's discuss the other drugs also here itself. So let me just make a summary for you. So first drug that you can use is what? First drug that you can use is insulin. First drug that you can use is insulin, right? That is the drug of choice in type 1. Second drug you can use is metformin. Metformin is the drug of choice in type 2, right? Apart from that, you can use sulfonylureas. Sulfonylureas, now you are in a better situation to understand what the sulfonylureas are going to do. Look here, they are going to directly block this pump, ATP sensitive potassium channel. They are going to blocked by sulfonylureas, leading to what? Depolarization, accumulation of potassium inside, leading to what? Entry of calcium. Entry of calcium will lead to release of insulin. Insulin मतलब चाबी कहाँ गई? Again in the blood. Same story is happening, right? So you will be having this sulfonylureas. These are going to work on ATP sensitive potassium channel. These are going to work on ATP sensitive potassium channels, right? And how you can remember, all these drugs will be having G plus ide. glimepiride, gliclazide, gliblancalamide, glimepiride, all these drugs are going to have G plus ide. These are going to be your sulfonylureas. Apart from sulfonylureas, we are going to use what? Incretin. Drugs which are like incretin. Simple understanding. This particular thing, GLP-1, this is known as incretin, and basically it is going to responsible for the regulation of insulin, regulation of release of insulin. But simple words you can remember what? More incretin means more insulin. So whenever you want more insulin, you can increase the incretin, right? And how you can increase the incretin? Simple understanding, incretin will lead to increase the insulin, right? So we are having two things. We are having this GLP-1. Remember, this GLP-1 is the incretin analog, right? And now this GLP-1 is going to broke down with the help of an enzyme that is going to be DPP-4, right? So what I can do, I can use GLP-1 agonist because I want to increase incretin. This is an incretin, this is a incretin. So I want to increase incretin. I can do what? I can give agonist. I can give agonist drug. So we are having GLP-1 agonist. These are the drugs which are having glutide in their name. Glutide, GLP, glutide. These are proteins. You can remember, these are glucose peptides, these are glucose tides, these are the proteins, right? So we are having glutides, like we are having semaglutide, we are having liraglutide. Okay, so these are the glutide we are having. Then second thing, this DPP-4 is breaking this GLP-1. So what I can do, I can block this particular enzyme. If I can block this DPP-4, what is going to happen? There will be increase in the levels of GLP-1, right? And these are the drugs which are going to be gliptins. These are the drugs which are going to be gliptins. DPP-4 inhibitors are going to be your gliptin. We are having drugs like sitagliptin, vildagliptin, linagliptin, sitagliptin. Okay, so these are the gliptin. Remember, the question they have asked you is on the linagliptin. We have to take this drug even we are having the kidney failure or liver failure, तो भी इसको ले सकते हैं. Even in the cases of kidney failure, this is safe, right? So these are the classes of drugs we are having. Then we are having SGLT2 inhibitor. I've told you in proximal part of the PCT, we are going to have a pump that is known as sodium glucose like transporter 2. It is going to block what? ये PCT में होता है, लोकेशन पे क्वेश्चन है. Second thing, it is going to do what? It is going to absorb 100% of glucose which is going out. और जब तक ब्लड ग्लूकोज 180 mg डेसीलीटर है, तब तक पूरा ग्लूकोज एब्जॉर्ब कर लेगा, right? So what we want now, we don't want our glucose to be in the blood. So what I can do, I can block this pump. Now what will happen? Blood glucose will be decreased, right? So what will happen? This extra glucose which is getting reabsorbed from the kidney, what will happen? It will be going out in the kidney, right? So you will be having drugs like gliflozin. Glucose flows in urine, right? So that is going to be gliflozin. Like we are having dapagliflozin, empagliflozin, rapagliflozin. These are the drugs we are having for the SGLT2, right? Then we are having alpha glucosidase inhibitor. These are the drugs which are going to prevent the breakdown of glucose and breakdown of complex carbohydrate into glucose, right? तो ग्लूकोज ही नहीं बनेगा तो ग्लूकोज ब्लड में कहाँ से आएगा, right? So these are going to complex carbs, whatever we are eating, they are not going to get converted into glucose. They are going to stop the conversion, right? What are the example? We are having drugs like acarbose, voglibos, or miglitol, right? Last, we are having drugs like pramlintide, which is going to be a amylin analog. It is a drug which is just like your amylin, we are having insulin and amylin, they are coming together. So what will happen? Whenever we are going to increase the amylin, what is going to happen? Insulin is also going to increase. Okay, ultimately we are increasing the key or we are decreasing the blood sugar. That is the ultimate concept we are having. Last, one more class of drugs we are having. These are going to be your glitazones. We don't use them very generally now they are PPAR. They are going to stimulate PPAR gamma. They are going to stimulate PPAR gamma. These are the drugs we are having, like rosiglitazone, pioglitazone, troglitazone, rosy, pioglitazone, right? These are the drugs we are having. We don't use them very commonly nowadays, right? Because they are having issues, right? They are having risk for liver toxicity, bladder cancer, right? So these are the drugs we are having. These are the all drugs we are having, right? So now try to answer. We are also having some complications of diabetes. Let's see the complications also. So what are the complications we are having? Before that, let me make you understand how to make the diagnosis. How to make the diagnosis? We are using the American Society of Diabetes 2021 guideline, and through that we can assess the diabetes with the help of certain things, right? So fasting glucose कितना होना चाहिए? Values, cut off values बता देता हूँ. Fasting glucose normally it should be less than 100 mg per deciliter. अगर प्री डायबिटिक है तो 125 से कम होगा. 100 to 125 can be there. If it is a diabetes, then it means it should be more than 126 milligram per deciliter. It should be more than 126 milligram per deciliter. HbA1c cutoff, if you want to see HbA1c, that is going to be less than 5.6% for normal. Okay, less than 5.6 for normal, 5.6 to 6.4 for pre-diabetic, and more than 6.5 is going to be for the diabetic person. More than 6.5 is going to be for the diabetic person, right? What is the treatment goal? What is the treatment goal? ये प्रीवियस ईयर क्वेश्चन है. ट्रीटमेंट गोल हमें हमेशा क्या रखना है? HbA1c का काउंट. इफ समवन इज ऑलरेडी डायबिटिक, then we need to maintain the HbA1c at 7%. Very very important, 7% or below 7%. Less than 7% will be the right answer, right? Second thing, what is the cutoff? The second question they have asked you, cutoff for HbA1c is going to be 6.5. Cutoff is going to be 6.5%. Both the questions are different. Okay, don't confuse, both of them are PYQs. Both the questions are different. Cutoff कितना रखना है? That is going to be 6.5. But HbA1c कितना होना चाहिए for good control? This is for the good control. This is for the good control. That should be HbA1c should be around 7%. That is going to be the good control. You can have complications of diabetes, like you can have macro and microvascular complications. We can have retinopathy, we can have nephropathy, we can have neuropathy, right? Macrovascular mein we can have stroke. We are having risk of cardiac diabetic cardiopathies will be there, and extremities pain can be there, right? These are the symptoms we are having, right? One more thing, the question they have asked you on the decay. So what is diabetic ketoacidosis? What is diabetic ketoacidosis? What will happen? Diabetic ketoacidosis mein patient is not taking insulin, so there will be decrease in the insulin. If there will be decrease in the insulin, what will happen? The counter hormone from the alpha cells, glucagon will increase. The glucagon will increase, and now this glucagon is going to increase your blood sugar. It is going to increase your blood sugar, right? And this sugar is going to precipitate diuresis. Sugar बढ़ेगी तो क्या होगा? Diuresis. That is why we are having what? More urination, polyuria, right? Apart from that, this this glucagon is going to activate your beta 3 receptor. Beta 3 एक्टिवेट होगा तो लाइपोलाइसिस होगा, लिपिड टूटेगा. लिपिड टूटेगा तो क्या बनेगा? You will be having ketone body formation. You will be having ketone body formation. You will be having formation of lipid, will lead to ketone body formation. Another thing it will be doing what? It is going to cause what? This lipolysis is going to cause what? Acidosis. This lipolysis is going to cause what? Acidosis. So these two things will happen. Now what is going to happen? What are the different ketone bodies we are going to have? Three ketone bodies are important. First one is your beta hydroxybutyric acid. Beta hydroxybutyrate, very very important, right? Second one is going to be acetoacetate, and third one is going to be your acetone. Third one is going to be your acetone. Acetone की वजह से तो fruity odor आएगा. It will be giving you fruity odor, right? Beta hydroxybutyrate is the important one, right? The most important is going to be this one particular. right? Apart from that, what is going to happen, this acidosis is going to cause what, acidosis की वजह से क्या होगा, I have taught you acidosis मतलब H plus बढ़ गया, H plus बढ़ गया मतलब क्या बढ़ेगा, CO2 बढ़ेगा, and whenever you are going to have more CO2, the patient will do rapid breathing, right? And what is this rapid breathing is known as, this is known as Kussmaul breathing. The patient will be hyperventilating, patient will be hyperventilating, just trying to throw out the excess of CO2, right? That is what is known as hyperventilation, right? You will be having the fruity odor here. The patient will be having dehydration because of urination. Patient will be having nausea, and abdominal pain can be there. Abdominal pain can be there. Okay, so this is the image you will be getting with the diabetic ketoacidosis. Ketoacidosis के patient में क्या होगा, these are the main problem. First problem, he will be having acidosis leading to Kussmaul breathing. He will try to remove the excess CO2. Second thing, he will be having excess of ketone bodies will be there, beta hydroxybutyrate. And third thing, because of diuresis, he will be having what, dehydration. So for treatment, now if you understand the pathology, treatment will be very easy. Treatment क्या करना है, first thing, every patient will be dehydrated. You have to do what, hydration. Most important thing for the treatment is hydration. Second thing, you will be giving this patient what kind of insulin, regular insulin, everything will be normal but after that, right? Two important things you need to do, DK patient में hydration देना है और regular insulin देना है, right? That is what is important. So for this particular question, the answer will be telmisartan, guys. Telmisartan. Dapagliflozin क्यों नहीं देंगे? Because he is already on norfloxacin. He is already having a side effect of UTI. I have taught you recurrent episodes of recurrent fever, right? Recurrent fever episodes. Norflox is a UTI drug, right? 400 mg we are taking TDS, right? So he is already having UTI. We are not liking to give the dapagliflozin. Captopril has not as such use for this particular thing, right? And what about this metoprolol, which is going to be a beta blocker? We are avoiding that. Beta blockers, beta cells will be suppressed, right? So the drug of choice that we are using here is ARB. In fact, this telmisartan is a drug which is having activity of PPAR gamma, which is going to be known for reversal of diabetes mellitus type 2, insulin resistant, which is going to be reversal for insulin resistant, right? So this is very very important, special feature with this particular drug. So patient with diabetes and hypertension, the drug we are preferring is what, the drug we are preferring is telmisartan. Type 2 diabetes with hypertension, telmisartan is a good choice, right? Next question, we are having a 35-year-old man presented to OPD with the complaints of epigastric pain. Epigastric pain is there. Patient is having epigastric pain. Okay, which relieved on further eating. By now, I think you must be understanding what I want to talk about. Is it a type of ulcer, right? And constipation is there. Galactoria is a feature you will be finding where, on examination, we found elevated levels of prolactin. Is there. Hypercalcemia is there. And on endoscopy, a tumor is noted on the duodenum. Duodenum will be having a tumor. What can be the likely diagnosis in this particular case? Diagnosis क्या होगा यहाँ पर? Patient को epigastric pain है, which relieved on further eating. कौन से अल्सर का पेन रिलीव होता है फर्दर ईटिंग में? दैट मीन्स अल्सर लाइज इन द गैस्ट्रिक रीजन और ड्यूodenum. गैस्ट्रिक में अगर अल्सर होगा तो वो खाएगा तो उसको वोमिटिंग होगी, राइट? तभी पेन रिलीव होगा. खाएगा, एसिड रिलीज होगा, this pain will be aggravated. So gastric ulcer pain, whenever he is eating will be aggravated. Whereas duodenum में अगर pain ulcer है, it will be relieved on further eating. Those people who are eating something every 2 to 3 hours, they are having duodenal ulcers, right? Another thing we are having, so first thing we get to know, this patient is having some kind of a duodenal ulcer. And the question is also stating that this patient is having, on endoscopy we are finding a tumor on the duodenum. So what is this tumor can be? Either this can be a ZES, Zollinger-Ellison syndrome, which is a G cell gastrinoma, G cell tumor, and G cell is responsible for more acid production, right? Apart from that, second thing we are having is Galactoria means there will be breast milk coming. Milk is coming from the breast, and we are also stated that this patient is having high levels of prolactin. The prolactinoma is there. Prolactinoma means there is high levels of prolactin, and prolactin has a function pro. That means production of milk. It will be producing the milk, right? Third thing we are having is hypercalcemia. What is the gland which is concerned with the calcium? The gland which is concerned with the calcium is parathyroid gland, which is going to responsible for the increase in the calcium. ये बोन को तोड़ेगा और ब्लड के अंदर कैल्शियम बढ़ाएगा, राइट? सो वी आर हैविंग अ ट्राइड जोलिंगर एलिसन सिंड्रोम, prolactinoma, which is a pituitary tumor, pituitary adenoma we are having basically, right? And we are having parathyroid hyperplasia, right? What is your diagnosis? Zollinger Ellison syndrome, nicardipine? No, it is not Zollinger Ellison syndrome. Zollinger Ellison syndrome will be having only that particular concept of hyperacid acid will be there, right? There will be only and only acid will be there. That means there will be ulcers, right? This is a man syndrome. Very important topic. Look here, this is a man syndrome. The man one is going to have what? Man one is going to have a pituitary adenoma will be there. Pituitary tumor. In our case, we are having what? We are having prolactinoma, which is a pituitary tumor. Second thing, we are going to have parathyroid hyperplasia leading to what? Hypercalcemia. This is what is happening. And third thing is going to be a tumor which is in the GIT, that is going to be a pancreatic mass, right? So we are going to have what? This is going to be man 1 syndrome. This is going to be in the favor of man 1 syndrome. And remember, man 1 is also known as Wermer syndrome. It is also known as Wermer syndrome. Location, if they have asked you, chromosome number 11q. Chromosome number 11q is the location. That is for the man 1. What about man 2 syndrome? This is known as Sippel syndrome. Also known as Sippel syndrome. Man 2 hai. Remember, it will be having parathyroid hyperplasia, medullary carcinoma of thyroid, and pheochromocytoma. Pheochromocytoma is present here, both of them. Here we do not have pheochromocytoma. First one is pancreas, second one is going to be your pheochromocytoma, right? Man 2b and man 2-1, both of them are associated with, look here, both of them are having RET gene mutation, RET proto-oncogene, and the chromosome which is involved over here is going to be chromosome number 10 in man 2a and man 2b. Man 2a is known as Sippel syndrome. Man 2b will be having mucosal neuromas. This pheochromocytoma will be present. This medullary carcinoma will be present. Two things will be added. One is mucosal neuromas. Another one is your Marfanoid body habitus. Even if you remember this particular thing, it will be more than enough to solve this question, right? So what is going to happen here? Is it a Wermer syndrome? Now I think you will be able to answer. The patient is having duodenal ulcer. Patient is having prolactinoma or pituitary adenoma, right? So this is not a direct case of just pituitary adenoma or Zollinger-Ellison syndrome, but this is a case of Wermer syndrome. Very, very important question. Wermer syndrome, because it is a man 1, multiple endocrine neoplasia type 1, man 1, right? That is going to be Wermer syndrome. These are your man syndromes, right? The next question we are having, a 42-year-old female patient is a known case of hypertension. She is having hypertension, presented with episodes of palpitations. She is having what? Palpitation. She is having sweating along with the cramps in the muscles. She is having muscle cramps. ABG is showing what? Metabolic alkalosis. She is having metabolic alkalosis. And what can explain this particular situation? What this patient is going to have? This patient is having which disease? What is the diagnosis? Your diagnosis here in this particular case is going to be what? Diagnosis, metabolic alkalosis. Diagnosis here is going to be your Cohn syndrome. Let me make you understand. This is going to be your Cohn syndrome. Okay, let me make you understand what is adrenal gland. Adrenal gland will be having two parts. One is going to be your cortex, another one is going to be your medulla, right? Cortex में क्या होगा? We will be having three layers, G, F and R. G will be there, F will be there, R will be there. G for glomerulosa, zona fasciculata, zona reticularis, right? Glomerulosa, this was your previous year question, 24 exam question. Glomerulosa is going to release what? It is going to release aldosterone. देखो पहले salt, फिर sweet, then sex, right? So aldosterone will be coming from the zona glomerulosa. Then we are going to have glucose, glucocorticoids will be there, or cortisol, you can say. You will be having glucocorticoids from fasciculata, that is going to be cortisol, and reticularis will be releasing what? DHES. Okay, and medulla is going to be responsible for epinephrine, norepinephrine, and dopamine. They are collectively known as what? They are collectively known as catecholamines. This was the question they have asked you. They have given you image of the zona glomerulosa and asked you what is the thing which is going to come from here, right? So aldosterone is going to come here, and I have told you aldosterone forward story. I have already taught you in physiology. Here also, today also, I have taught you aldosterone is going to kidney now and doing what? Water and salt reabsorption, right? It is going to make ENAC channels, and your potassium and hydro H plus channels will be there. It will be leading to influx of sodium along with the water. That is the aldosterone function, right? Now, what are the things you will be having in the Cone syndrome? Let me make you understand. Simple understanding. If you understand this, so this is your aldosterone. It is going to make what? Sodium channels, potassium channel will be there, H plus channel will be there. They are going to make sodium, epithelial sodium channel, ENAC channels. What is the function? Here you are going to have what? Urine formation. This urine is going into collecting duct. What will happen? Now this ENAC is going to absorb what? It is going to absorb sodium along with water. So what is going to happen when it is going to absorb sodium along with water? It is going to do what? It is going to have more sodium, more water, leading to what? Hypertension. That is what is happening in the question. It is going to lead to what? Hypertension. Apart from that, it is going to do what? It is going to do release. If it is taking the sodium inside, what will happen? It will release something. It will release something. It will release K plus and H plus into the urine, right? If K plus is excreted into the urine, what is going to happen? You will be having hypokalemia, and that is what is explaining the muscle cramps in the patient. That is what is explaining the muscle cramps. And third thing, if this H plus is going away into the urine, what is going to happen? The patient will be having metabolic alkalosis, right? Metabolic alkalosis will be there. So all these things are given here, and if you understand this, if you remember this, it is very easy, right? If you don't remember, no problem, revision makes you perfect, right? Don't worry about it, right? So what is the investigation of choice in this particular case? We are going to check the saline infusion test. We are going to do saline infusion test. And what is the treatment? So treatment is pretty simple. Just block this or block this so that no sodium is coming inside. If no sodium is coming inside, these things will not go outside. Just potassium sparing diuretics are the treatment. So we can use drugs like spironolactone. For Cone syndrome, we can use spironolactone. We can also do unilateral adrenalectomy. एक साइड के एड्रेनल को हम उड़ा सकते हैं. दैट इज गोइंग टू बी one of the treatment, right? So in this particular case, the answer will be Cone syndrome. But what are these Addison's disease and Cushing syndrome? Let's try to understand this also. So we are having this Addison's disease. It is going to be a autoimmune disease, beta. It is going to be a autoimmune disease. Decrease in the levels of adrenal hormone will be there. So what are the adrenal hormones I have taught you? I have taught you about the aldosterone. There will be decrease in the aldosterone. There will be decrease in the cortisol. There will be decrease in the DHES. So these are the parts of the adrenal cortex. They will be decreased, right? And here you will be having increase in the levels of adrenocorticotropic hormone. ACTH बढ़ जाएगा, जो बार बार आके किसको स्टिमुलेट करेगा? Adrenal gland को. And now adrenal gland will not be able to work because it is having some autoimmune disease, leading to what? Decrease in the levels of all these things. Investigation of choice क्या होगा? IUC, that is going to be SCTH stimulation test. Here you are going to do SCTH stimulation test. और ट्रीटमेंट के लिए you need to give what hormone replacement therapy. Hormone replacement, not hormone, basically we are going to replace the things. We are going to replace what we are having decrease in the cortisol, so we are going to give hydrocort to the patient. Hydrocortisone or fludrocortisone we can give. We can give sex steroids to the patient, right? So we need to give these things from the outside. That is going to be the treatment for the Addison's disease, right? Next we are having is Cushing syndrome. Let's discuss some important points about the Cushing syndrome. Cushing syndrome. Cushing syndrome, how the presentation will be there. The patient will be having moon-like faces. He will be having moon-like faces. Moon-like faces will be there. Lemon on stick appearance will be there. Lemon on stick appearance will be there. लेमन ऑन स्टिक मतलब ऐसा होगा, पेट भारी होगा और जो हाथ पैर है वो पतले पतले होंगे. दैट इज व्हाट इज नॉन एज लेमन ऑन स्टिक अपीयरेंस. दिस पेशेंट विल बी हैविंग व्हाट hypertension. This patient will be having hypertension. This patient will be having excessive growth of hairs on the body. That is what is hirsutism will be there. Hirsutism. Why this thing is happening? Generally these things are happening because of like long term steroid intake, right? If someone is taking steroids due to like any disease, if someone is taking steroids, it can lead to Cushing syndrome, right? Cushing syndrome. What else apart from the steroids we can have things like malignancy. Even malignancy can also do that, right? Which malignancy? We are having a cancer that is known as lung carcinoma, that is oat cell cancer. That can also lead to this. We can have pituitary adenoma. We can have pituitary ka cancer, pituitary adenoma, which is going to release what? Which is going to release increased levels of ACTH, right? And this is what is known as Cushing disease. Whenever we are having involvement of pituitary adenoma and leading to increased levels of ACTH, this is known as Cushing disease. Cushing disease. देखो Cushing syndrome में क्या होगा? We can have buffalo hump, we can have abdominal stria, all these things will be present, right? But what will happen in the cases of like this Cushing syndrome में सारी चीज़ें होंगी, right? But Cushing disease में क्या होगा? Whenever we are having involvement of pituitary adenoma, that is what is known as Cushing disease, है ना? तो दोनों separate entity है. Cushing syndrome अलग चीज़ है, Cushing disease अलग चीज़ है, right? How you are going to treat this situation? How you are going to treat? So first of all, you need to identify the cause and you need to treat the cause. Treat the cause. What are the drugs you can use? You can use drugs like ketoconazole. We can also use drugs like metairopone. Okay, so ketoconazole, it can cause suppression, right? Ketoconazole, metairopone, these are the drugs we can use, right? This is pretty much you should be knowing about it, right? Next is your pheochromocytoma. What is this pheochromocytoma? Pheochromocytoma. Now, this is a tumor of adrenal medulla. This is a tumor of adrenal medulla. Adrenal medulla tumor. Generally, it is benign, but it can be malignant as well. Adrenal medulla tumor. Adrenal medullary tumor. Right? Here you will be having episodic hypertension. They can write you things like episodic hypertension is there. Patient is having symptoms of diaphoresis. Patient is having symptoms of anxiety because of increased release of epinephrine. Epinephrine is going to go to your beta receptors. It is going to cause hypertension, anxiety, palpitations will be there. How you will get to know? You will be having increase in the levels of very important increase in the levels of VMA, valinol mandolinic acid. That is going to be your thing you have to remember for the pheochromocytoma. You can also have increased levels of epinephrine, norepinephrine, dopamine. That is going to cause different effect. Catecholamines will be increased basically. Catecholamines will be increased, so you will be having increased epinephrine, increased norepinephrine, increased dopamine. All these things will be increased means what? They are the sympathetic nervous system neurotransmitter. You will be having more activation of sympathetic nervous system, right? Apart from that, how you will check? You will check for the levels of these things in the blood. You can check epinephrine, norepinephrine, or dopamine in the blood. You can also check, you will be finding increase metanephrines. Yes, very good. It will be having rules of 10. Rule of 10 will be present, metanephrines. And in the urine you can find the levels of VMA will be increased. The levels of VMA will be increased in the urine. You can check the levels of them. In fact, some people, like I know a case, he's having all these symptoms and he has been visiting to psychiatrist for such a long time, but this patient can also have what? This patient can also have pheochromocytoma, right? Because all these symptoms, diaphoresis, anxiety, palpitations, can be symptoms of this particular disease also. So when you are going to do the scanning, how you will identify? You can go for CECT scan, and in that CECT scan you will be finding that light bulb appearance. You will be finding that light bulb appearance. And before going for the treatment, you will be doing what? You will be doing surgery, right? So during surgery, what can happen? You can accidentally cut the medulla and you can lead to release of lots of epinephrine, right? That can cause shock, that can cause hypertension in the patient. He can have hypertensive crisis, right? To prevent that, we are giving alpha and beta blocker. Preoperatively we can use phenoxybenzamine, right? We can use drugs like phenoxybenzamine, or sometimes we can use post-operatively, or during the operation we can use phentolamine, right? We're generally using alpha plus beta blockers so that all these symptoms should not come, right? We can use it. One more entity you can remember, that is going to be your carcinoid syndrome. Carcinoid syndrome. What is this carcinoid syndrome? It will be having increased levels of that is your serotonin, right? So you will be having this carcinoid syndrome. The patient will be having what? Flushing over the face will be there. Flushing, more carcinoid, more flushing will be there. You can have diarrhea because serotonin is going to increase the motility of GIT, right? You can have wheezing. But the most important thing, most important clue that I want to teach you is going to be 5-HIAA. The levels of this particular thing will be very high, and this is going to be the investigation of choice in the cases of carcinoid, 5-HIAA. And for the treatment, you can use somatostatin analogs like lanreotide. You can also use octreotide. Right? So this is for the carcinoid. Now, a 35-year-old female is having symptoms of weight gain. This patient is having weight gain. Cold intolerance. This patient is also having the intolerance to the cold, right? Fatigue is there. Hair loss is there. Fatigue is there. On examination, HLA, DR3, 4, and 5 is noted. Which antibody can be associated with this particular disease? Which antibody is going to be associated with this particular disease? Yes. Waiting for your response. Which antibody is going to be associated with this particular disease? So what is this LETS? What is your diagnosis first? What is your diagnosis? Your diagnosis in this particular case: weight gain, cold intolerance, fatigue, hair loss, HLA-DR3, 4, 5. I think you are searching anti-TPO somewhere, right? So we do not have anti-TPO here, but the diagnosis in this particular case is going to be your Hashimoto or hypothyroidism. Basically, you can say hypothyroidism, better term, right? So you are having this hypothyroidism, right? You are going to have is hypothyroidism. So what are the symptoms you will be getting always in the cases of hypothyroidism? A patient will be there, and this particular patient is going to have what weight gain. She's just drinking lots of only water, and still she's getting fat. She will be having symptoms of hair loss will be there. It is a very prominent symptom, right? She's having hair loss. Okay, she's having weight gain. She's not even eating anything. Her metabolism is slow. She will be feeling she's cold intolerant, right? So all these symptoms, she is always having the fatigue. All these symptoms are the symptoms of hypothyroidism, right? So let me make you understand what is this hypothyroidism. So basically this thyroid gland will be making what, T3 and T4. And these T3 and T4, let me make you understand the pituitary axis first. So you will be having hypothalamus, it will be releasing TRH, it will be coming to the anterior pituitary, and anterior pituitary is going to release what, TSH. And now this TSH is going to thyroid gland, and thyroid gland will be making what, T3 and T4. And now this T3 and T4 are going to your blood. It will be binding with the TBG and all those things, transthyretin, and it will be doing what, it will be doing its function. It will be going to your beta receptor activation. It will be causing activation of beta receptor. That is why we are having palpitation in the cases of like we are having thyroid storm, right? Whenever we are cutting the thyroid, we are having lots of thyroid hormone going to the heart. It will be activating your beta receptor, leading to palpitation. That is why we are using like propanolol also, right? You should be remembering that. Now what is going to happen, this particular thing is the basic thing. Now whatever things you are eating, it will be having iodine. This iodine is going to come into the blood. Now this iodine is going to go into a cell, right, via this sodium iodide symport, which is a type of which is a secondary active transport, right? Now what is going to happen, this iodide ion is going to come inside, and this iodine is not utilizable now. So this iodide is going to come into colloid. This is your colloid, right? Now what is going to happen, this iodide ion is going to get converted into iodine. This iodide ion is going to get converted into iodine with the help of an enzyme. This is known as thyroid peroxidase, and this reaction is known as oxidation. This reaction is known as oxidation. Now once it is converted into iodine, now this iodine will be having another step, that is known as organification. And now it will be making what, it will be binding with the thyroglobulin. It will be binding with the thyroglobulin, and it will be making what, if single ion is binding, that is going to make monoiodothyroglobulin. If two iodines are binding, it is going to make what, diiodothyroglobulin. Now this mono plus di is going to make what, it is going to make tri, and di plus di is going to make what, di plus di is going to make what, tetra, right? So you will be having this T3, you will be having this T4. This is how we are making the T3 and T4 from the iodine, right? Now this T3 and T4 is going to come back into the cell, and it will be getting stored, and it will be stored here, right, in the follicles. Right, now what is going to happen, whenever required, whenever this impulse is going to come from the, whenever this impulse is going to come it from the pituitary, and this impulse is going to come from the pituitary, it is going to stimulate your thyroid, and now your thyroid will be releasing what, T3 and T4, right? But if you are having problem, if you are having iodine deficiency is there, what is going to happen, you are not going to make anything, nothing, no reaction is going to be formed, right? So you will not have iodine, you will not have nothing, right? You will not make anything. So what is going to happen, if there is iodine deficiency, you will be having what, goiter. Why this goiter is happening, because sir, this constant stimulation, this TSH is constantly stimulating the thyroid gland, and thyroid gland stimulation will lead to increment in the size of the thyroid gland. That is what is known as goiter, right? So we can have like multinodular goiter, we can have toxic multinodular goiter. We are having goiter, and why this goiter is happening, because this TRH is stimulating this TSH, and now this TSH is stimulating this thyroid, but thyroid do not have iodine, so we cannot make T3 and T4, and that is why iodine deficiency can lead to goiter. Next thing we are having this PDS. If we are having mutation of this PDS, this is known as Pendrid. If we are having mutation of this Pendrid, what is going to happen, is there any possibility this T3 T4 is going to be formed? Even we are having iodine, but this is not going to be formed, right? And this syndrome is known as Pendrid syndrome, which is going to be presented with the goiter as well. Third problem we are having is this particular thing, these TPO enzyme. If we are having antibody against these TPO enzyme, what is going to happen? You are going to have a disease known as most common thyroiditis, that is going to be Hashimoto thyroiditis. And if antibodies are formed against this TPO, do you think any reaction will forward? No, there will be no oxidation, there will be no organification, there will be no coupling, there will be no T3, there will be no T4. And what is the treatment that they have asked you in the last exam? They had the treatment here, we need to give the levothyroxine from outside. And what we are giving, that is going to be levothyroxine, that is going to be the drug we are giving, Altrox or levothyroxine, whatever we are giving, that is going to be your T4 form. And how much you are giving, suppose if a female is having a weight of like 70 kg, right? Let's say 65-year-old female is there, and the weight of the female is like 60, let's say 60. Okay, so how you will give the drug? You will start it off with the minimum dose possible, that is going to be your 0.25 mcg, and then you are taking it to the level 1 to 1.6 times of the body weight, right? So you can go up till like maximum 0.75, or maximum you can go till 100 mcg, right? So you are going to see how you are going to increase. After 3 to 4 weeks, you are going to do what? You are going to do testing. You are going to do TSH, you are going to do T3, you are going to do T4 testing. Till the time this TSH and T3 T4 are normal, you are going to give the drug, right? In the adult patient, we normally start with the medium dose and then we can increase. But for the like elderly patient, we are having this guideline that we should be starting from the minimum dose possible, right? So that is going to be this particular thing. Another question they have asked you is what is like primary disease, secondary disease, or tertiary disease. Anywhere you can utilize this concept. If the end gland is involved, like we are having thyroid, if thyroid is involved, it is going to be a primary thyroidism, primary parathyroidism, primary thyroidism, right? If this TSH, if this pituitary is involved, it is going to be a secondary disease, it is going to be secondary thyroid, right? Secondary parathyroid. If this hypothalamus is involved, it is going to be a tertiary disease. This is what you should be remembering before exam, right? So Hashimoto thyroiditis, now you know the treatment. What we need to do, we definitely need to give levothyroxine from outside. That is going to be the treatment for the Hashimoto, right? You will be having certain symptoms in baby. If the mother is pregnant, you always need to supplement the mother. Okay, so these are the things. Next thing we are having like hyperthyroidism. Hyperthyroidism, the most common, that will be having formation of antibodies. These are the antibodies we are having, like long acting thyroid stimulating antibodies. We are having antibodies like TSI, thyroid stimulating immunoglobulins, right? We are having TSI. What are the symptoms this patient will be having? He will be having palpitations, he will be having increased metabolism. This patient will be a thin patient, beta. Thin क्यों होगा? Because he is having more metabolism. You must have seen some people are always agitated, running here and there. They cannot sit properly, right? They are thin patient, eating lots of things, but still they are thin. And on the other hand, there are some people that they'll just drink water and still they are getting fat. They will say like that. Okay, so this patient will be thin. Next thing, he will be having heat intolerance. They are always running towards the AC, right? Heat intolerance will be a feature. Remember, on thyroid scan, here you will be getting what kind of uptake? Here on thyroid scan, you will be getting a diffuse kind of uptake. Diffuse uptake will be there. Diffuse kind of uptake will be there. This hyperthyroid patient, what you want to do? You want to decrease the thyroid in this particular patient. Yes, it will be having weight loss, right? So what you can do for the treatment of this particular patient, you can use drugs like PTU. Okay, PTU is a drug you can utilize in the primary trimester also. You can utilize in the primary trimester, you can utilize it. Okay, first trimester in pregnancy. First trimester in pregnancy, which drug you can use? That is going to be your propylthiouracil. Okay, or otherwise the drug of choice is going to be your methimazole or carbimazole, because they can cause a specific side effect, that is going to be your aplasia cutis. So we are avoiding these drugs in the pregnant female, right? So otherwise they are the drug of choice. Apart from that, we can destroy the thyroid gland. We are having multiple drugs, multiple methods like Lugol's iodine, potassium iodide. We are having like iodine 131, which is emitting the beta rays, which is going to destroy the gland, right? So this is how we can destroy the hyperthyroid thing, right? You will be having these things, right? About thyroid cancer, if I want to talk about, you will be having, if I talk about the prevalence, you can remember the mnemonic that is going to be your please feel my abs. Please feel my abs. That is going to be the prevalence data. That is going to be papillary. First one, most common, is going to be papillary. Then follicular. Then follicular cancer will be there. Then medullary carcinoma of thyroid. Medullary carcinoma of thyroid. And lastly, anaplastic. One more thing, always remember F for FNSC is contraindicated. Follicular carcinoma, FNSC is contraindicated. You are not going to do the FNSC, right? Second, third trimester, you can use methimazole, carbimazole, right? Organogenesis will be there. Next question we are having, the last question. A 35-year-old male patient is presented to OPD with the symptoms of excessive urination. Excessive urination is there, increase the thirst, along with the hypernatremia, and confusion is noted. What can be the most likely diagnosis here? Very simple question, right? We are having polyuria, increased urination. We are having increased thrust, that is going to be polydipsia. We are having hypernatremia. This is going to be okay. This is going to be diabetes insipidus. Let's try to understand. We have already discussed about the mellitus part. Now we are going to discuss about the insipidus. What is diabetes insipidus? Let's try to understand. So we are going to have diabetes insipidus. One more thing we are having is SIADH, syndrome of inappropriate antidiuretic hormone. So both of them are working on the principle. ADH will be released from the, remember I've told you two hormones which are going to come from the hypothalamus, which are formed in hypothalamus. These are going to be your वो हार्मोन. कौन से हैं? V for vasopressin and O for oxytocin. वेसोप्रेसिन का ही दूसरा नाम क्या है? एंटी डाययूरेटिक हार्मोन. तो ये जो वो वाले हार्मोन है, ये कहाँ बनते हैं? ये बनते हैं हाइपोथैलेमस में, एंड दे आर स्टोर्ड इन पोस्टीरियर पिट्यूटरी. दे आर स्टोर्ड इन पोस्टीरियर पिट्यूटरी. दो ही हार्मोन है जो पोस्टीरियर पिट्यूटरी में आते हैं, राइट? सो फ्रॉम पोस्टीरियर पिट्यूटरी दिस वो और ADH हार्मोन इज गोइंग टू कम आउट, एंड इट इज गोइंग टू हैव three receptor, V1, V2 and V3. V1 is going to be present on the vessels, so it is going to cause vasoconstriction. Used in the cases, the name of the drug is terlipressin. थोड़ा बता देता हूँ. Terlipressin. Name of the drug is terlipressin. We are using this terlipressin in the cases of what? In the cases of esophageal varices. Whereas this V2 receptor are present on aquaporins. This V2 are present in aquaporins, and V3 are responsible for the release of ACTH. So what is going to happen in this particular thing? Let me make you understand. Okay, so this is your urine which is going out, and this is your cell which is having V2 receptor. ये तुम्हारा kidney हो गया, right? Now the urine is going out and it will be having V2 receptor. These V2 are what? These are aquaporins. Now what is going to happen? Whatever urine which is going out, it is going to take up the water. Aquaporins means सिर्फ पानी का uptake करेगा. Now what is going to happen? This water is going to come into body, right? This is the basic functioning. What happens in diabetes insipidus? There will be decreased levels of ADH, antidiuretic hormone. It can be two types of ADH. It can be due to neurogenic. Neurogenic मतलब brain से ही नहीं आ रहा, और you can also call it central. whereas another one is going to be your nephrogenic, मतलब kidney में कोई problem है. So where can be problem? Either the problem is in the brain, hypothalamus or posterior pituitary. Either the problem lies in the kidney. If the problem lies in the brain, we call it neurogenic or central diabetes insipidus. But on the other hand, if the problem lies in the kidney, we call it what? We call it nephrogenic, right? So what is the drug of choice for neurogenic? Neurogenic में क्या करना है? इसके जैसी ही कोई दवाई दे दो. That is going to be vasopressin का भाई desmopressin. That is going to be your desmopressin. Whereas in the cases of nephrogenic, we are going to use what? Thiazides. Thiazides are the drugs we are going to use. नेफ्रोजेनिक के लिए एक कोर्स याद रखना है. दिस इज योर प्रीवियस ईयर क्वेश्चन. दिस इज गोइंग टू बी लिथियम. Lithium can cause nephrogenic diabetes insipidus. What is the problem you will be having? The problem, same problem will be there. Polydipsia will be there. Polyuria will be there. Let me make you understand how this thing is happening. देखो, ये चैनल बंद हो गया, V2 काम नहीं कर रहा, ADH नहीं है. अगर ADH नहीं है तो what will happen? The urine will go away. The more urine will go away, that is known as polyuria. Second thing, urine बाहर जा रहा है but salt नहीं जा रहा है, right? Salt will be getting accumulated in the body, leading to what? ज़्यादा salt. जहाँ salt वहाँ पानी. You will be having more thirst. You will be having polydipsia. Another thing, you will be having more salt in the body, leading to what? You will be having what? Hypertension. You will be having hypertension, right? So you will be having hypertension, you will be having polyuria, you will be having polydipsia. What kind of urine will be there? Here you will be having diluted urine. On the other hand, if I want to talk about the SIADH, here you will be having increased levels of antidiuretic hormone, leading to what? More absorption of water. बहुत सारे V2 receptor बन गए यहाँ पर. बहुत सारे V2 receptor बन गए. What will happen? Lots and lots of water will get reabsorbed. यहाँ से water बहुत सारा reabsorb हो जाएगा, leading to what? Leading to बहुत सारा पानी आ गया, but the salt is going away. What will happen? Leading to dilutional मतलब dilute हो गया. Hypo मतलब कम. Natremia मतलब पानी ज़्यादा आ गया, सॉल्ट कम है बॉडी के अंदर. दिस इज नोन एज डाइल्यूशनल हाइपोनेट्रीमिया. इन द क्वेश्चन दे विल क्लासिकली राइट डाइल्यूशनल हाइपोनेट्रीमिया. यू नीड टू अंडरस्टैंड व्हाट इज हैपनिंग, वेयर इज हैपनिंग, राइट? सो दिस थिंग इज हैपनिंग एट दिस पर्टिकुलर लेवल. दिस इज द लोअर पार्ट ऑफ द कलेक्टिंग डक्ट, right? Here whatever urine which is going away, that is going to be your concentrated urine, right? And how you are going to treat this situation? You are going to use drugs like conivaptan and tolvaptan. Vaptans are vasopressor antagonist. In fact, one more thing you can remember, the exam is around the corner. You can remember, even in the cases of nocturnal enuresis, बच्चे रात को सुसु कर देते हैं, nocturnal enuresis, right? What you need to do? Nocturnal enuresis, what you are giving, the drug of choice is going to be your desmopressin again. Desmopressin. Why desmopressin? Desmopressin is a V2 analog. ये क्या करता है? ADH बढ़ा देता है. Now you will be having more ADH. रात को दे दी. What will happen? You will be having more absorption of water in the night. You will be having less urine formation. मतलब bladder नहीं भरेगा, बच्चा रात को सुसु नहीं करेगा. That is why we are having the drug of choice as desmopressin. Whereas second thing, we can use the treatment of choice, that is going to be your bed alarms, right? One more concept done, right? So with this thing, I take you bid, right? We are done with the most of the things that can be asked in your examination, right? And the last thing, we are having the code that we are having is a river cut through a rock, not because of its power but because of its persistence. So be persistent. You have done your hard work well, and the exam is really around the corner. So I hope all of you will pass with the flying colors. And we are having one more session. Maybe tomorrow we will be joining. I will be guiding you how to give examination, how to appear for the exam, and what are the things you have to take care just before going to your examination. All the important things that I get like within a lot of years. So that is what I'm going to give you tomorrow. So please do join the session. These are my Instagram and Telegrams in case if you want to connect with me. you can always connect with me. The PDF will be shared in my Telegram group. That is Dr. Vaibhav classes. You will be getting that after some time, right? So if you are having any issues, you can always reach out to me with any subject you are having, whatever I'm teaching you. You can have issue, you can always reach out to me. Okay. Thank you guys. Good night. Thank you.